injuries, a detailed clinical analysis. Dr. Yogesh, please.
It's a proud privilege to, start the 46th AMSI with the first lecture, and I take it as a proud privilege. I have no commercial interest to declare here, and in the next couple of minutes, I'm going to just take you through the surgical management of frontobasilar injuries. And I bring this presentation to you from this beautiful city of Shimla, where the first slide there, can I have the pointer please? The first slide is the picture of the facility where I work. It's a dental hospital. And the next picture shows the medical facility which is attached to our dental facility. So that's the medical facility there, that's the dental college there. This is the front of our hospital during the winters, and this is how this whole place looks like in the winters. A good treat to be there in the winters. So the outline of my talk is going to be basically based on some classification schemes which have been given time and again, trying to have some prognostic significance of these injuries. And then I'm going to discuss a little bit about neurosurgery component, because that's the primary area where we basically concentrate when we talk about frontobasilar injuries. And finally, I'm going to talk about the role of a maxillofacial surgeon as he has to deal with the frontal trauma, leading from exposure to fixation concepts to frontal sinus management, and a brief description about the NOE component. So in this very interesting publication, which was published in the Journal of Biomechanical Research in the year 2011 by Joseph Cormier and his friends, they talk about shifting trends in the frontal injuries. We all are familiar with the 1975 article by Nahum, the plastic surgeon, where he talks about forces in excess of 3,000 newtons to create frontal injuries. But here in this trauma, in this study, he's used acoustic sensors, and he says that forces required are much less than what actually are perceived, and he says 800 to 1500 Newton forces can cause frontal trauma. Then there is another very nice publication in the Journal of Plastic, Reconstructive and Aesthetic Surgery in the year 2015, where they have talked about the prognostic significance based on classification. Now it's very easy to understand. They basically first talked about the vault, and then they've talked about the base. So what they've done is that type 1 is a simple trajectory that we just saw in the last picture, this horizontal trajectory, that's on the frontal sinus. And type 2 is a vertical fracture involving the orbit, but not the frontal bone. This is the type 2. And then you go to the type 3, which is a vertical fracture involving frontal bone, but not the orbit. So likewise, they've just increased the classification into type 5, which is the last one, where contralateral and bilateral orbits along with frontal bone. So as we keep grading up in the injury, the classification keeps going higher. And then in the depth area, obviously, we are concerned with the anterior table and the anterior cranial fossa. Middle cranial and posterior cranial fossa is something we leave to the neurosurgeon. But even in the anterior cranial fossa, there's a very close coordination with the neurosurgical colleagues. And then there is this very landmark article by the legend Paul Menson in 2009 in Plastic and Reconstructive Surgery, where he again talks about a very simple classification, where type 1 is a base fracture, type 2 is a linear base and vault fracture, and type 3 is a combination of both these areas. So when you talk about the frontobasilar repair, it's a multi-speciality approach. You'll have to have a team of people looking at these injuries, and basically in the primary stage it's the neurosurgeons who basically try to do some emergency surgeries, but in definitive management also sometimes neurosurgeons have a role, and then ophthalmic surgeons for globe injuries and optic nerve injuries, and finally the maxillofacial surgeons who repair the cranial vault, because nobody knows the cranium like them. So what are the goals of frontobasilar repair? If you look at it, the first, as I said, is the neurosurgical decompression or evacuation of the hematomas and the intracranial repair, which is obviously done by neurosurgeons. And then there is the globe and the optic nerve repair done by the ophthalmic surgeons. And finally, there comes in the maxillofacial surgeon when you start talking about the orbital roof, the frontal bando, And when you talk about the frontal sinus cranialization, when you talk about obviously the open reduction and internal fixation of cranio-maxillofacial buttresses. I'm going to take you to this basic anatomy slide of the intracranial anterior fossa. And as you can all see that the cranial nerves 1 and 2 are very intricately associated in the anterior cranial fossa fractures. So we have to keep in mind the injuries to these two areas, and plus we have to also talk about the cribriform plate from where usually there's going to be a dural rupture and CSF leak. So a brief word about the different types of traumatic brain injuries that you may see in these patients. There can be contusion of the brain, which basically requires a unifrontal or a bifrontal craniotomy, and then you need to remove the contused part of the dead brain. And then we all commonly see subdural hemorrhage. The treatment of choice again over there is craniotomy, and then you go in for removal of the clot with patties, followed by coagulation of any bleeding sources if you can identify them. And then finally the extradural hemorrhage, where again you need to perform a craniotomy, but here you sometimes need the coagulation of the middle meningeal artery. That's what the neurosurgeons do there sometimes. And then they also tie the superior sagittal sinus, which is a very important source of bleed in these injuries. And then finally dural hitches are given in the frontal area, which is basically a superior suspension of the dura in this area. And then you need to refine the bone edges with bone wax. And subarachnoid hemorrhage, we all know, is a medical emergency, and these people are usually on life support. Nothing much you can do except coagulating the source. So this is a picture of the craniotomy. I'm not going to go into the details. This is the anterior cranial fossa exposure after retraction of the brain, and I want to acknowledge my neurosurgical colleague, Dr. Digvijay, who's given me this slide. And if you can see there, after the retraction of the brain, that's the retractor there, you can see the anterior cranial fossa pretty clearly. And this is the ligation of the superior sagittal sinus that I was talking about. You can see the suture over there, and you can also see the threads hanging down. And after that, when you stitch up this dura, you need to suture it up in a slightly higher position. That's what are called dural hitches. A CT scan of an extradural hemorrhage, you can very easily make out over there that how the bleed pushes the brain, and that needs to be addressed by simple, sometimes burr-hole surgeries, but nowadays craniotomies are the treatment of choice. Okay, so I'm again going to take you to another very interesting publication by Rave et al. Way back in 1988, where they talk about one-stage management of combined craniofacial and frontobasal injuries. What they've basically done is that they have given some incisions in the supratarsal area from where they go subcranially. They are not talking about the coronal approach over there. And based on this article, they've again given a classification where they talk of basically NOE fractures with frontal component, but you extend it to the base. So if there is no base involvement, it's a type 1. If there is going to be involvement of the optic nerve, it's a type 1A. But when there's going to be base involvement or the frontobasilar trauma that we're talking about, it's a type 2 fracture as per Rave's classification. And this is a very recent classification on pediatric frontal trauma, the first ever classification on pediatric frontal trauma. And this was published in the Journal of Plastic Reconstructive and Aesthetic Surgery in the year 2020, very recent, by Lopez et al. Of course, Paul Manson is one of the contributors here also. Very simple to understand. Again, they are going according to the seriousness of the injury in children, just the vault injury, type 1, and when the vault involves the orbit, type 2, and when this injury extends downwards into the maxillofacial region, that's a type 3 injury. So ladies and gentlemen, this finally brings me to the maxillofacial component of this talk. We talk about the frontotemporoparietal injury, which this is what it looks like when you actually take up these patients for a definitive management, the complete skull crushed. So the management of frontal trauma for a maxillofacial surgeon, I believe, is first of all to learn about the surgical exposure, then the frontobasilar repair. Finally, we address the nasofrontal NF40 tract, and we address the frontal sinus by obliteration and cranialization. And last of all, we go in for the anterior table restoration. This is the coronal exposure, which is basically showing a depressed fracture of the frontal bone. You can see the frontal sinus involvement there. You can see the frontozygomatic sutures. So excellent incision to give you a complete exposure of all these injuries, and you can plan your reconstruction. And it's a very versatile exposure for final evaluation of the reconstruction also. You can see how the entire area has been plated. Now, one of the things that I want to discuss over here, we've all heard about the maxillofacial buttresses, but this is the cranial buttressing system. We basically have the buttresses around the cranium, and if you look at it, the buttresses just leave this sinus area, rest of the vault, the sagittal suture, the supraorbital rims, those are the external buttresses, and those are the internal buttresses of the intracranium. Now, how do we fix these injuries? We will talk about the fixation concepts, and we'll talk about the, first of all, when you open up these injuries, you go in a step ladder fashion. You need to restore the cranial base first of all, because that's the injury which is hidden over there. So you repair this base, and then there is the final restoration of the anterior cranial base. And when you look at the CT scans of these patients, look pretty satisfying from this kind of injury leading up to there. And one of the components that one very beautifully gets to restore is the orbit. You're repairing the cranium, but you get to restore the orbit. Another picture of the same CD scan and a lateral view of the same CD scan just to evaluate these injuries. So I'm going to now talk about the restoration of the frontal bando. This is the frontal bando there, and you need to use different contraptions, the cranial meshes, the plates and screws and whatever, to fix up this very strong buttress of the supraorbital area. I'm going to show you a little bit of my work experience in this area, individual case illustrations. This is a frontobasilar injury in a 16-year-old lad. He actually fell down from a mountaintop, and this is how he sustained this injury. And if you look at these orbital roof fractures, there is the pseudotosis you can see there, and there is restriction of the upward gaze, and forehead and upper eyelid ecchymosis is there. And if you look at the CT scan of these people, there is evidence of pneumocephalus. You can see air pockets there because of the pushing of the frontal bone inside. And when you basically in definitive stage try to reconstruct these children, the results are pretty satisfying. That's the surgical repair of this gentleman. You can see the disruption there, and after restoration, this is how this looks. So frontal bone and orbital roof fractures are pretty common in our area because ours is a mountainous topography, and most of these patients have injuries sustained because of falls. And this is how they look on CD scans, and you can see the disruption that's caused, and this is how we repair them, the standard maxillofacial reconstruction, keeping in mind the buttressing system of this area. Another picture of a frontobasilar reconstruction where we are addressing this patient surgically like this. Sometimes you have to actually solve a jigsaw puzzle, and this is how it looks like after a final reconstruction. But the CT scan is very, very satisfying from here to here. Again, you decompress the orbit along with the cranium in these people. Another picture of a comminuted frontobasilar injury. This guy was hit by a stone by somebody, and the bone was so comminuted that we couldn't fix it in any way, so we used a cranial mesh, and this is what it looks like after the reconstruction. So let's talk about a little bit about the frontal sinus fractures. If the anterior table fractures, the reason for reconstruction should be if it's displaced more than the posterior table. That's the time you get a bad aesthetic defect there, and you need to reconstruct this. And for posterior table fractures, obviously you have to surgically address them by obliteration or cranialization. We'll be just coming to that in a minute. And this nasofrontal outflow tract needs to be addressed very carefully because that's the area where you get meningoceles later on. So we usually, for addressing the sinus, harvest the pericranium and we fill it up for obliteration in the frontal sinus. And after that, we go in for some contraptions like cranial meshes which cover the area and we reconstruct it. But sometimes if the posterior table is extensively managed, I'll just take 2 more minutes. If the posterior table is extensively involved, we need to remove the posterior table and cranialize it, and that's how this looks. And then finally we can put the anterior table on top, and the cranial vault looks over there. So ladies and gentlemen, I think the audiovisual system is just switched off. Can you give me 2 minutes for conclusion? Just the three last slides. 3 last slides.
Please
There's
go ahead.
Sorry? It's over?
Yogesh, you can go ahead.
Oh, okay, thank you. So ladies and gentlemen, I'm not going to go into NOE fractures now, restore the buttresses there. There's a lot of data I had put in there. But in conclusion, summary of management of these frontobacillar injuries is you need a good exposure, you need a step ladder reconstruction of these injuries, and the final repair after restoration is what it looks like. So in conclusion, I want to say frontobacillar fractures often present with open head injuries and optic nerve or globe injuries and requires a multi-speciality approach for optimal outcomes. Neurosurgeons, ophthalmologists and maxillofacial surgeons are required to manage these injuries, and after stabilizing these patients for the head injuries by neurosurgeons, maxillofacial surgeons restore the craniofacial architecture for better functional and aesthetic outcomes. Thank you very much for your kind attention.
Thank you, Yogesh. Fantastic presentations.
And management of NOE fractures, an Indian perspective. The presentation will be by Dr. Kannan Balraman of Ganga Hospitals, Coimbatore.
Big show, and I think it's an onerous task nowadays, and they've hit the ground running. So this talk is part of a session which is looking at the frontonasoethmoid region, and I'm kind of a filler between the frontobasilar and the actual nasoethmoid region. So there's a debate following the talks. So the remit when the scientific chairman told me was to discuss about, no, the previous one is to talk from an Indian perspective, what do we do and how we go about managing this. So as a, yeah, there we go. So as a disclaimer, there's no funding received, and all patients' photographs, we routinely consent them for use for scientific presentation and publications. So if you're taking pictures, please don't post them on social media. We need to respect their privacy. So NOE complex, thankfully, Yogesh didn't steal my thunder. The NOE complex is, as we know, is the intricate area in the face which joins the face to the brain. The challenge there is any deformity there is striking and in your face right away. The nature of the injury is such that if you don't treat them well in the beginning, there is an obvious deformity, either gross or mild, and it is difficult to make it go away completely. So the first time is the best time. And this has been recorded even from our own classic text, Rowan Williams. There is a general statement saying, yeah, anything beyond 2 weeks in NOE is not going to give us a good result at all. So that part of the face which joins, which integrates the nose, eyes, and just at the base of the skull is what picks up the eye. The same remit, it is easy to mask deformities there without surgical option, but still there is an obvious deformity. So as the previous speaker alluded, so it is part of the facial buttress systems and at the upper half. This is the only fracture, at least in the facial-maxillary skeleton, where we are interested with the soft tissue attachment as well, the medial canthal tendon attachment, along with the bony pattern fracture. Conventional Rowan Williams was just unilateral, bilateral, associated with the other fractures, but now we know that we are more interested in the canthal tendon attachment and how the relationship of it is affected with the fracture pattern. Just to understand the canthal tendon, though it is, we read it as a tendon, there is an anterior limb, posterior limb with a roof, and there is nothing underneath. So it is spanning the lacrimal fossa. So any injury to this system, we are not going to be able to reproduce it exactly like a tent. We will only be able to do it at one point, and that's why we enter at the posterior-superior aspect when you are doing a canthopexy. The commonest presentation, at least from our perspective, which we see in our practice, is RTAs, because it's unique with two-wheelers forming the bulk. The challenge with two-wheelers is people without helmets, they go and crash either the handlebar or they go and hit the opposite vehicle right on to the base of the skull. And that's when the NOE is affected. Falls are also there, and when they go and hit against a wall or a gate, and this is the region which hits them first. And of course, assaults. There is another pattern of injury which is described mostly ophthal see it more than max fax until us or even other trauma units, wherein when they are changing dress in a hurry, all the metal projections or the hooks in the dress catch the eyelid and then make a tear there. The classic presentation, which is the same, it is always a jumbled up bones and the soft tissue following up the jumble. The challenge here is, however well the secondary correction is, the soft tissue doesn't adapt well. Imagine the soft tissue like a tent which is held up by the poles. Once the poles collapse, which is the bony projections collapse, the tent falls down. It is like that, the soft tissue falls down and just scars over there. When we reposition the bony dorsum again, or whatever we do to get the bones in the right place, the challenge is the soft tissue doesn't respond as well and it still has that scarred effect. So we lose the texture and the skin texture and the skin quality there. The second challenge is, if unaddressed, there is another associated problem with regard to injury to the nasolacrimal duct. So even if you don't identify if the bones are put in the right place, there is a good chance NLD remains patent and it doesn't form a secondary problem, whereas if not corrected and if it's displaced and the NLD is blocked, we tend to have recurrent infections there and the bulge of tissue, making the situation worse. So this is just to say, historically we are not bad, we go in like that, how the NOE complex has evolved, and even our treatment, our understanding of the fragment, if you look through history from nasal to FNOE now, and same thing from wiring to plating now. So this is over 70 years from the West, and we don't need to reinvent the wheel, we just have to go in and check them and see why they have changed from wiring to manipulation of the fragment to plating to the case of bone grafts in certain instances, either primary or secondary. But the most classic classification, or from a treatment point of view, is what we do, Manson and Markowitz, which we do, which relates both the type of fracture to the medial canthal tendon attachment. Whether if the fragment is the only fracture or main fragment is attached to the fragment, or the fragment is so small or completely detached. So when it is associated with other injuries, it is imperative, and it was, though it is 30 years ago, it still holds good, how to go about fixing the fractures. Get the rim. The most important thing is exposure. The reason I am saying this is sometimes we find even local exposure with an existing laceration does the job. Get the rims, get the hard parts of the bone with thick buttresses better, and then go in for attaching the tendon. Finally is only the dorsal build-up. The most flimsy bones are reconstructed at the end. So this is what we saw, and this is to illustrate sometimes the local laceration gives us as good an exposure as a bicoronal flap. Bone grafts help sometimes if it's gross comminution. Putting the fragment holding the tendon alone is not sufficient. A depressed dorsum gives a view of pseudo-telecanthus, and then trying to do secondary rhinoplasty and then trying to address it later also gives an additional challenge. If possible, sometimes it's a challenge deciding whether to go in straight away or later. This is just to illustrate, even with a local laceration, if you put in a bone graft, we will still get adequate, reasonable results. And the advantage of a bone graft primarily, if possible, is it will mask all the secondary deformities. As in this case, you might see that though we have put, there might be a light laxity of the fixation, but still the stretched skin with the bone graft masks. Otherwise, these injuries which have a hood, which are degloved, you can see the extent of degloving. When we put them back, we need to do a good soft tissue draping. If you restore the height, the advantage is the skin is fully stretched and the laxity of skin is taken away and it heals well. Once it heals well, it is fine. But if we leave the soft tissue laxity there, that bulge is still there and takes a long time to go away, or doesn't necessarily go away at all. This is the classic two-wheeler fixation which we talk about, where a handlebar or they go and hit a projectile and involving the skull base, as the previous speaker alluded to. So it is involving the skull base, ethmoid complex completely, with the nose pushed in. And we can see the projection of the nose is also lost completely. You can see the entire nasal dorsum has moved halfway up the ethmoid. So when it goes into the ethmoid complex, automatically the medial walls flare out. In these cases, it is imperative we do a combined approach. Nowadays, the advent of multidisciplinary team approaches helps us in achieving optimal results straight away. So this is a classic reduction, fixation, plus or minus duroplasty, and we get the results. Because the fragments are intact, kind of like Markowitz type 1. It is fractured, but it is intact, just moved away. We just need to pull out the dorsum, only then we can reduce the ethmoid, nasoethmoid into place. The same thing sometimes is done locally, however grotesque, we may avoid or we can avoid until otherwise we understand. But the key here is to ensure that the posterior wall of the frontal sinus and the base of skull is not involved. Then we can go ahead with the local flap. So when you are looking at only the outer table of the frontal sinus with the associated nasoethmoid. Again, classic two-wheeler injury where you can see the skull base anterior table gone in along with the nasoethmoid completely rotated to one side, which doesn't fit in the classic fracture pattern. Once we reduce and get them back, a close reduction also sometimes does the job, because most of them are green sticking there. We reduce them, they are in position, you get them in, not necessary for us to always plate. Local lacerations sometimes are degloved so much, even for a complex injury like this we will be able to do, wherein the entire fragment is rotated and moved out of position. The challenge here is ascertaining the associated medial wall of the orbit, floor, medial wall of the orbit are also restored adequately when we are doing. So that is the challenge, and we get the correct jigsaw in the correct place, we will still be able to do it. So they are degloved so much, and when they are degloved, once we put the bone back in position and then repair the soft tissues, we need to ensure that there is enough pressure on the soft tissues to keep draping the bone. So there's no laxity and there is no edema which is pushing away the soft tissue from the bone. Sometimes in these, if you don't do primary rhinoplasty, that is the challenge. We lose the nasal, keystone area is lost, wherein the bone is fine, but the cartilage bone junction is gone. And that is the advantage of doing a primary rhinoplasty. But in this case, because the dorsum, if the dorsum is comminuted, we know we go ahead straight. But these instances is difficult, and we need to ensure that we may have to go in for a secondary rhinoplasty. Sometimes as part of panfacial, though it looks grotesque, all we had to do was expose them. The fragment, just push it back into place and hold it in place with plate, wire or whatever it is, and the ensuing defect. Put the bones back, and then if you are doing primarily, that is the advantage and easy. Secondarily, when they come, the bulge, recurrent infection of nasolacrimal duct, it is difficult to get the soft tissue draped until otherwise we excise them. But however we excise them and repair, that look is still there. We can get a sharp pinch of the canthus, but still getting them closer in a scarred area is not that straightforward. This is the disadvantage of doing a secondary correction later. So we can get away with the NLD obstruction, repair it, restore the patency, but still then that is the challenge, and the look of a previous injury is still there. Again, the advent of local approaches there with our conventional maxillofacial approaches, so you can get them. But remember, in a degloved area, this is just to say the highlight that you might lose the lateral canthal tendon. You are looking so much at the medial canthal tendon, we lost that with the scarring and not repositioning it in the right place. So the next challenge is sometimes, this is what I meant, which our ophthal colleagues see more often than us, but sometimes it comes to us. This is an assault where only the soft tissue is degloved. So it just cut exactly, there's no bony injury at the nasolacrimal duct region, as well as severing the canthal tendon completely off it. So that means not only reconstruction, if the duct is injured before the sac, then we do what is called a mini Monaka stent. If the sac itself is injured, then we have to go in for conventional NLD reconstruction. So here, putting them back in place, just medial canthopexy to the same side, not to the opposite side, still gives, because there's no exact bony involvement. This is to show that the cannulation, if there is a cut there, we can just cannulate it and bypass it. And this is not as uncommon. There's no bony injury, soft tissue degloving. But when we are looking at soft tissue degloving, we can see that entire nose is degloved. It's like your reverse facial degloving approach. But when we put them back, just getting the canthal tendon and hitching them to the periosteum, maybe anchoring it again 2-3 times helps us to hold and avoid this bulging there. So we were looking at our own results over a 2-year period with close reduction, with plating and with bone grafting. So this was about 22 patients who are specifically in type 2 and type 3. Type 1 injuries, we know that it's straightforward, only control the fragment. The challenge comes only in type 2 and type 3. So this is the demographic inconsistent with what we see with other fractures. Males are most common and RTAs were the most common. Association, of course, ZMC injuries and with other panfacial injuries is part of RTA, or skull base injuries, or identifying them independently as NOE. The soft tissue ones weren't included as part of this study. So close reduction, as we saw in one of the previous cases, were done in 5. About 2/3 of them had open reduction and fixation, and 3 had primary bone grafting. So this is how we tend to go and assess our post-operative results. Projection, both frontonasal angle as well as the projection from the lateral canthus globe and the nose. So if you can restore this or almost close to this, then you have got a good aesthetic result. And then of course, our to ensure that we have corrected the telecanthus, the projections. So in a bilateral fracture, or if there is a gross laceration, it is difficult to ascertain or measure them exactly. The simplest is look at the width of the opposite eye and then start mirroring it to each side. So when we looked at them, elevation and stabilization, when there is gross comminution, when the fragments are intact, you can get away with it, and if it's mostly green stick, but we still find some under projection of the nasal dorsum. Bone grafting for the comminuted injuries, what we found is sometimes we tend to overcorrect the frontonasal angle. But if you can do an ORIF, associated plus or minus bone graft, that gives us the best results. So in our scenario, RTAs are still good, and if we can combine a multidisciplinary approach, if NLD is included, and do it off at the first sitting if possible, or within the first admission, we tend to get the best results. Thank you.
A good one, sir. As he has already told, NOE fractures to be treated as early as possible at the first sitting. Now, having an overview of management of NOE fractures, we go upon to the challenges and complications by Dr. P. Ananthanarayanan. NOE fractures, challenges and complications.
This invite. So I'm just going to start where Kannan ended. So he's given you all the pros and cons of management of NOE fractures and what kind of complications we can anticipate. So that is where my lecture begins. So let's start focusing more on the complications because we can understand the challenges better. The acute complications, as we all know, relate more to hemorrhage, epistaxis, visual disturbances, as well as tearing problems. We are more interested in managing the delayed complications, which are telecanthus, saddle nose, diplopias, enophthalmos and hypophthalamus, the problems with NLD obstruction, soft tissue scarring, and the frontal sinus. Let's handle them one by one. For better clarity, what I felt was we can categorize these challenges into these 3 components. So you can have ocular, orbital, or adnexal challenges. You can have nasal and frontal challenges, as well as age-related challenges, the extremes of age group. So let's start with the most basic. We all attribute the MCT to be the significant point of NOE fractures anytime. So when you're looking at MCT and its identification, let's have a perspective between the local approach and the coronal approach. Remember that local approaches are more direct. You can actually observe and identify the anatomy of the MCT much easily. But when you're looking at the coronal approach or a delayed scenario, remember that identification of the MCT itself becomes a significant challenge. And one important aspect of this is using a transcaruncular incision, a minimally placed transcaruncular incision using a transcaruncular barb or a transcaruncular suture if the barb appears to be too expensive for you, and that can ensure you taking a good bite on the MCT. This was the description given by Beat Hammer. Now, this is an underdog which is often left out in most discussions of NOE fracture, so I felt I should take a lot of interest in this. Remember that NOE in our most perspectives is an aesthetic correction. We all think that just correcting the telecanthus and reducing the epicanthal fold is what NOE is about. No, it is not. NOE has a very functional aspect to it, and that is formation of the medial canthal angle and redraping the eyelid onto the globe. The essence of this is formation of a tear trough, which helps to form a tear film and ensures excellent drainage of the tearing through the nasolacrimal system. So generally people present here with epiphora, rounded canthal angles, or a hidden caruncle. Remember that when you have rounded canthal angles, you will end up with a hidden caruncle. And you can already see this on the photograph there. These are all the classical findings, and you can actually achieve that. The yardstick for that is aggressive debulking of the fibrous tissue, redraping of the medial canthal angles, dead space elimination, and creating the right vector. This is able to oppose the lid onto the globe again, forming the tear film. Now remember, if you have an ectropion in that region and the puncta is actually away from the globe, your tear system is not going to work in spite of a patent NLD. So that's one significant challenge which is often less estimated by maxillofacial literature. The next one is concomitant orbital fractures. We all know you can have involvement of the medial wall, floor or roof. You can have involvement of the EOMs, extraocular muscles, which can be medial rectus, inferior rectus, or superior rectus. Remember that the main structural support for the canthal anchorage comes from the medial wall. So this is simple algorithm for us to determine when to perform concomitant fracture managements. It's very easy when it's early or delayed, because you can handle both of them together. The orbital reconstruction can be performed simultaneously. What happens when you have a slightly delayed presentation of the patient? There your soft tissue is not organized, it is not scarred, the scarring is not mature. That creates a real dilemma. So there you look for problems related to the orbit first. Are there changes in positions of the globe? Are there extraocular motility problems? Then you handle the orbit first. Wait for the soft tissue scarring to establish itself, maybe by even 4 to 6 months, and then handle the NOE and the PEXI. Now this is a representative case which has a type 3 NOE, a gross orbital defect of the floor and medial walls. Patient also had chronic dacryocystitis and ptosis. The reconstruction plan was full reconstruction conjoined with the NOE area as well as the orbital defects on the medial wall as well as the floor. You had the medial canthopexy performed and the simultaneous DCR. That's the restructuring of the medial wall so that we get adequate anchorage for the medial canthal pexy. And this is the final results. So secondaries can be challenging, but a good and thorough sequencing and planning can ensure good results. Navigation, of course, is an interesting tool. It can be very, very important when you're handling difficult areas, secondary corrections, and you want precise outcomes. Another case which had involvement of the roof and floor, and then you had tethering of the superior and inferior recti, you had gaze restrictions. The plan here was simultaneous orbital reconstruction, NOE PEXI, and release of the superior rectus and the inferior rectus to establish good unrestricted gazes. So the CT scan is demonstrating the fibrosis of the superior rectus as well as the inferior rectus. That's the release and re-establishment of the muscular course. This is the projection of the globes, which seems to be extremely satisfactory, and you have the change in gazes. The focus is on the inferior and superior gazes. Now, we've seen that in the last two cases, there is a lot of incidence of ptosis. So please remember that ptosis can be a concomitant factor in NOE fractures, especially the frontonasoethmoid complex fractures. And the most common cause is either the tethering of the levator, or you can have a frank injury to the levator. Secondary management can be done always after projection of the globe and re-establishing the globe position. Lacrimal apparatus, Kannan has already mentioned about it quite a bit, but I will walk you through what are the different phases and how you can manage it. You can have features of epiphora, positive rhoplus. Rhoplus is regurgitation on pressure over the lacrimal sac, and you have sometimes positive CT dacryocystogram findings, and you can have it with or without suppuration. The aims are to restore bony architecture, re-approximate the lid globe relationship and the patency of the lacrimal system. Now this is quite a complex chart, but please remember that simultaneous addressing of the DCR as well as the NOE is possible in most instances, except for places where you have suppuration, where you drain the abscess, wait for some time, systemic antibiotic therapy, and then follow it up with definitive management after a latency period of 3 to 4 weeks. Case of traumatic nasolacrimal duct obstruction with NOE fracture, you can see that the stoma is prepared along with the fracture repair, and that is your result for secondary correction with simultaneous correction of the NLDO as well as the PEC-C. Suppurative dacryocystitis, bilateral dacryocystitis, one side with suppuration, one side not without suppuration, can be managed concomitantly, except that this abscess was drained, latency period of 3 to 4 weeks, and then conjoined procedures. Next is the nasal function and aesthetics. Remember that nasal function is also compromised in cases of certain NOE fractures, where the frontal process of the maxilla goes inside and then forms retarded breathing or compromised breathing. That's also very important. Here the focus is restoration of bony architecture, importance of reducing the frontal process of the maxilla, as well as dorsal reconstruction. Results following redo for a comminuted NOE with a 2-stage reconstructive process. There was no bone in the central fragment, so we had to mesh reconstruct it with the first stage and the second stage for dorsal reconstruction. Frontal sinus management has already been lucidly elicited by Dr. Yogesh, so I'll skip it. Please remember that the change comes when the FSOT is involved, and if you have a compromise of the sinus tract outflow, you have to take that into concern and then address it. Walk you through a few cases. It's a non-complicated type 1 NOE where both the ducts are patent. This is for basically the residents get to understand the frontonasal recess. Bilateral drainage systems are intact. Ipsilateral drainage blockade with mucosal formation, managed with ablative process of the mucosa as well as obliteration. And this is more profound mucocele. Again, you had ablation as well as obliteration. The next one is extremes of age challenges, pediatric fractures. The article which was shown by Dr. Yogesh also carries the largest series. It's marked here, it's Lopez et al. It's a wonderful read coming from Chicago as well as Baltimore. And it involves the largest series of fronto-nasoethmoid complex fractures in pediatric age groups. Although there is a consensus saying that you don't actively or aggressively manage pediatric fractures, let's remember that pediatric patients also need aggressive management when warranted. The nasal reconstruction can be delayed or thought about in a little form, because you want the patients to kind of harness the growth spurts that are available. But if you feel that there is a need for aggressive management, do not let the age deter you. Go ahead and do aggressive management. There is a role for bioresorbable implants, but sometimes the structural support offered by these are not adequate, and you may need to use titanium hardware. Make sure that you go ahead and remove it in about 6 months when the age group is less than 8 or 9 years. The contralateral problem is with geriatric patients, not much in detail. Make sure you choose the best cases when you want to really address them. Most of them do not have, if they don't have functional deficits, don't handle the geriatric patients. But if you feel that they are functionally compromised, go ahead and then handle them, but with the bare minimum of needs. So to summarize, the management of nasoethmoid complex, it happens to be the pinnacle of trauma surgery. It's very similar to rhinoplasty for plastic surgeons or facial plastic surgeons. The challenges, remember, are not only aesthetic but also functional. Remember that NOE or medial canthal tendon does not just mean traumatic telecanthus, which is a problem with cosmesis. It's got a very, very serious functional problem in managing epiphora, which is not a comfortable process for most of us. So remember that MCT management is not telecanthus alone, it's redraping the lid onto the globe and creating a potential for management of a tear film, which can be comfortably drained with a neutral position of the punctum. Like what Kannan said, it's 30-35 years since the sequence has been laid out, but it still holds good. You have to focus on your exposure, identify the medial canthal tendon, construct the outer framework well, then the walls, get structural support for the MCT PEC-C, perform the PEC-C. It can be transnasal or ipsilateral depending on the needs, manage the nasoseptal complex with the dorsal projection, and then excellent soft tissue management. That's the key for all. So let's focus on this, which was quoted by Atul in his book. Most patients ask for perfection, but it's not reasonable. What is reasonable is that we never cease to aim for it. So with that, I think I will conclude my talk, and I hope I have fulfilled the pathway which was cleared by Kannan, and I've answered most of the questions which was put forth by him after his presentation. Thanks a lot for your patient listening.
Thanks, Anand. May I call upon Dr. Amit. He is going to present on bicoronal flap, its role in frontal fractures. Dr. Amit.
I'm Professor Dr. Amit Mahajan, working in KM Shah Dental College in Vadodara. Today my talk is on bicoronal flaps role in frontal bone fractures, and it's a video presentation. So I have compiled a video to how to develop the flap and how to go in for the treatment. This is my disclaimer slide. The patient's consent has been taken, and the whole work belongs to us. Good morning, Indore. So this is, I'll start with the video. I would like to thank the people who have helped me to reach this position. Everybody knows them. The patient is Suraj Magre and complains of fluid from the left eye, but his main problem was the aesthetic correction, that is the depressed glabular region. He had a malunited fracture, old fracture. He didn't want treatment for any of these things. He just wanted an aesthetic correction for the frontal bone fracture. You can look, the frontal bone is depressed. Both the anterior and the posterior tables are fractured. So in consultation with our neurosurgeon, he said that we should go only for onlay graft. So these are the indications of bicoronal fracture, and these are the modifications: hairline fracture, sinusoidal, sawtooth coronal, and a classical bicoronal fracture. In this video I am presenting a classical bicoronal fracture, how to harvest. These are the skin layers of the scalp: skin, subcutaneous tissue, occipital frontalis galea, galea epineurotica, areolar plane, and pericranium. So first step in the video is the preparation of the patient. The preparation is very essential for the surgery because it might lead to infections and some things like that. Also, we in this video demonstrate a simple classical bicoronal flap with takeaway home tips so that it makes easy for everybody to learn this flap. You see the incision just now, it has been cross-hatched at various places. So cross-hatching is done so that the final closure is easy. What we are discussing in this video is
superior temporal line
arising from FZ, below which the burr hole is done, and it is one of the landmarks for Pieten-Guy's line, which forms the anterior margin of the frontal branch of the facial nerve. It passes from the root of zygoma to the external angle of the eye, or the burr hole, which is below the FZ. So this is the Pieten-Guy's line forming the boundary of the facial nerve. We as max-fac surgeons follow this a lot. After giving an incision on the root of the zygoma, a 45-degree angulation incision is given and the flap is raised on the zygomatic bone. Between two
superior temporal line.
The incision is simple, that between two superior temporal lines we give an incision directly on the bone, and then an artery is passed over the temporalis fascia, deep temporalis fascia, and through incision is given on both the sides. Since we are above the temporalis fascia, the facial nerve will be preserved. The incision is made parallel to the hair follicles through the galea in the loose areolar plane, leaving the periosteum intact. In case we are going to develop a pericranial flap, we have to go below the periosteum and reflect the flap in toto. Degloving flap is raised. In case we are not going to develop the pericranial flap, we will go above the loose areolar tissue, do the dissection, and about 2 to 3 centimeter above the supraorbital rim, we will place the incision. Now for retraction, the artery can catch the galeal layer without catching the skin flap. This will preserve the skin flap without having indentation on the skin flap. You can see very clearly that we are catching the galea and retracting the flap. Now we have to be sure the classical bicoronal flap. The flap can be raised by a simple maneuver by taking gauze pads and sliding the whole flap over the bone, just like peeling off from a surface. Now the subperiosteal plane is maintained till the defect of frontal bone is exposed. We will remain over the deep temporal fascia, and in case we require to expose zygomatic arch, we have to go below the superficial layer of deep temporal fascia. Actually, when we are, this is the supraorbital and supratrochlear nerves being exposed in bicoronal flap. And we can proceed for the dissection with either a cautery or periosteal elevator. Again, emphasizing the point that in case of exposure of zygomatic arch is required, we have to follow Peyton-Guy's line. That is, we have to place an incision from the root of zygomatic arch towards the external angle of the eye, exposing superficial temporal fat pad, and then raising a flap on the bony surface of the arch. This is how we have exposed the depressed frontal bone fracture. Patient didn't agree for an osteotomy when we explained about the associated complications which might occur. So he wanted a onlay graft. So what we did was a mesh repair with raising a pericranial flap and a graft, harvesting a pericranial graft and filling the defect with this. This is FZ exposed depressed frontal bone fracture. Now the mesh is adapted and fixed over the defect. Now this is how the mesh is adapted. We have taken the margins of the mesh. It is being designed to get adapted to the frontal bone. The fixation of the mesh is done, and the mesh has a little play in it, and it might irritate the overlying soft tissue. So what we do is, after adapting the mesh, we tap it with a mallet, Teflon mallet, and adapt it nicely across the skull base. Now this is how the mesh is adapted. Very nice little unforceful tabs, minimum force tabs, and we fix it on the cranium. now a pericranial flap is being developed. Pericranial flap can be developed while raising a bicoronal flap. We can keep the pericranium on the vault, but the incision is quite messy. The hemostasis is difficult to achieve. This way, the pericranial flap is bit difficult to develop, but then it is not impossible.
A pericranial flap is developed which is used as a separator as well as bulk filling material in the defect. There is also a graft harvested from posterior flap of the pericranium which is also used to fill the defect.
Now, this is the pericranial flap elevation, a rectangular flap. The size can depend upon the amount of pericranium you require to fill the defect. This pericranial flap is used in various procedures, anterior skull base surgeries and the sinus surgeries, the sinus repairs, cranialization procedures, and this is the pericranial graft being harvested to increase the bulk more. These black clips are autoclavable clips. We use them routinely. They are economical and give us a good result. On the root of the nose we have contoured the mesh and we are pushing the pericranial flap little bit over it to drape it, and this is how we have achieved the final result. And we place a pressure dressing over the graft so as to stabilize it, and it is already in the depression. This is how the patient looked after the mesh repair. The mesh is nicely adapted, if you see that, and this is the 6-month follow-up from the frontal view, and this is the 6-month follow-up from the superior view and the lateral view. So the take home message is prepare the patient properly. If not done, can lead to infection. When injecting LA for hemostasis, one of the procedure to achieve hemostasis is injecting LA. The LA should be injected in the galea, so subgaleal layer. It will be very forceful while you are injecting, but you will get a nice hemostasis. If you are developing a pericranial flap, you have to go above the pericranium if you are learned in that way, but we prefer it to go below the pericranial flap, raise the bicoronal flap, and then develop a pericranial flap from that area. To prevent indentation on skin layer, the galea should be catched for the retraction. Layer-wise closure and drain or pressure dressing is surgeon's prerogative. In case you have to expose the associated zygomatic bone fractures, you have to follow the 45-degree angulation incision, expose the zygomatic bone, zygomatic arch, and do the subperiosteal dissection on the zygomatic arch. Also, when trying to develop a flap on the temporal region in bicoronal flaps, you have to go with a curved artery over the temporalis fascia. You have to cut through and through in the temporalis fascia. I think And these are my references. This is my team where I work. And thank you.
One where a bicoronal flap is presented in front of Dr. Edwards, and for me it is a proud moment in chairing this session. Thank you 46 UMSI for giving us a opportunity to chairing this session.
Great time starting with the first session of the 46th AMSI National Conference Indore. And once again, I welcome you all to Indore. For our first session, I would request our chairperson for this session, Dr. Venkat Salapathy sir and Dr. Gopal Krishnan sir, to please present a certificate and memento to our speaker, the opening speaker for the day, Dr. Yogesh Bhardwaj sir. Please, can I have some round of applause, ladies and gentlemen? Thank you. Them in the front, start moving the tables. Our next speaker, Dr. Kannan Balaraman sir. Dr. P. Anant Narayan. Sir, come from this side this way. Dr. Amit Mahajan. From here, we'll move on to our next very interesting part of the session, that is the debate, the grand debate, the contentious NOE, to do or not to do. I would request our chairperson, Dr. Venkat Salapathy sir and Dr. Gopal Krishnan sir, to please chair this session, the debate session. I would call upon our honorable chairperson to please begin with the next session. Thank you.
After the presentations of surgical management of all the injuries, we go to the debate of NOE fractures, the contentious NOU, whether to do or not to do. Now we call upon the debaters. First we call upon the moderator, Dr. Yashaswini. The debaters are Dr. P. Elevenil, Dr. Rohit Punga, Dr. Girish Gowda, and Dr. Imran Khan.
A difference, like we have a lot of debates. We just listened to the talks on management of naso-orbitoethmoidal fractures. So there is not much to debate on whether we need to do it or not. So then what are we going to debate on? So that's what we're going to see. I would like to first of all, thank the scientific committee for having extended this invitation to us. And I would like to welcome and introduce all my debaters on stage. Elevenil Paneerselvam, who is a professor, SRM Dental College, Ramapuram, Chennai. Rohit Punga, professor and head, maxillofacial surgery, Shraddha University, Noida. Professor Imran Khan, who is the faculty of dentistry from Jamia Millia Islamia, New Delhi. And Girish Gowda, who is with the Sanjay Gandhi Institute of Trauma, Bangalore. Thank you, Mr. Chairpersons. I would like to acknowledge Dr. Venkatachalapathy sir and Lieutenant Colonel Gopal Krishnan. Thanks for this opportunity. So, do you guys have a mic? Okay. We just saw how important the central segment is to the face, isn't it? When we first meet a person, we always look at them in the face, we look at them in the eye. So that is the most catching feature for anybody. So when that gets traumatized and when it is distorted by trauma, it can be quite disfiguring. So before we bulge into the debate, we're just going to ask quickly our panelists, our debaters, how they would go about doing this. How many of you would actually, what approach would you use for this patient? I would like you to look at the slides. Take a look at what you're seeing. Right. So what would be your approach, Venal, for this patient?
Through the laceration.
Okay. Did you notice
It's
posterior
right
table
over
comminution?
the- Yes, yes. Does the patient have CSF leak? Would that?
No, she did not have active CSF leak.
Okay, in that case, yes, right through the laceration.
Okay. Rohit?
Yeah, even I would prefer going through the laceration first, and
Im-
if the need be, then extend.
Imran?
For this case, existing laceration.
Girish? All of you are in sync with the laceration?
Until unless if there is no any CSF rhinorrhea.
Okay, so no CSF rhinorrhea. How would you approach the canthus? Rohit? Quickly, please.
I think we'll go transnasal.
Okay. Girish?
I think I can go for ipsilateral, ma.
Venal?
Yeah.
Ipsilateral again.
Imran?
This can be done transnasal.
Okay, what will you do with the nose? How many of you will vote for primary reconstruction of the nose? How much is needed? Venal can go.
I would prefer a primary reconstruction.
Okay,
Not at this stage.
not
I
at
would
this
wait and
stage.
see.
Okay.
Not at all. Since there is no any much communicated fracture, I don't think.
Right, moving on to our next case, what you can see here, very obviously you can see the avulsion of the medial canthus tendus. What would be your choice of approach for doing the canthopexy, Imran?
I think this should be ipsilateral, and same we can go through this existing incision.
Okay. Girish?
Is there any? I can see a CT scan or MRI.
Good. No, this is only a soft tissue injury. This is a case that I borrowed from Kannan. This is only soft tissue. No
Because
bone injury.
it all depends upon how you do do the ligament.
Same side or contralateral?
Depends upon the continuity of the medial orbital wall. If there is a comminuted fracture of medial orbital wall,
It is continuous.
yes,
It is continuous.
medial wall is continuous. Then I can go ipsilateral.
Venal?
Ipsilateral again, if the frontal bone is adequate enough.
Right. Rohit?
I'm not very sure with ipsilateral here still because the canthus is detached. It's a Markowitz type 3 kind of a situation. So
Okay.
I have my doubts.
Right. So quickly moving on to the third case. As you can see here, this was also previously shown by Kannan. Please look into the scans. There is significant comminution, disruption posterior table, loss of nasal support, and this is the 3D CT. So what would be your choice for this patient? As you can see, he has multiple lacerations. He also has posterior table involvement. So let's go quickly with the approach. How many of you would do a combined approach? How many of you would go for a laceration? Raise hands for combined approach, please.
Combine.
Combined. Okay, all of you. What about the nose? Primary, secondary?
Primary.
Secondary?
Secondary.
Okay. And what about the canthus? How would you go about doing the canthus?
Canthus, canthus I go for a ipsilateral because the whole it looks like a type 2 fracture.
Right.
So I can go for ipsilateral.
Okay. So this is the contention in NOE. We all know that canthopexy has to be done, but some of them would want to do it unilateral, some of them would want to go contralateral. And we all know that the nose has to be done. Many of us would not do it primary for many reasons, but many of them will do it for many reasons, although it has to be vouched. So like this, we have this is now the debate going to start. So we're going to see what approaches would be best. How do we do the canthopexy? You can see our debaters have contentions that some would go ipsilateral, some would go contralateral. And how many of them would address the nose primarily? If yes, why? If no, why? Right? So let's do the approach first. I would like to first call Imran to give his points of support.
Yeah, I would generally prefer seeing the intricate anatomy of the FNOE complex.
You have 5 minutes to defend your statement.
Yeah, thank you. Seeing this intricate anatomy and this complex anatomy this FNOE complex presents to us, I would always like to have a good access to my surgical site. At the same time, I would also like to have a good exposure to all my other fractures in case if the frontal sinuses are also involved. And I generally prefer bicoronal approach, as it was very well shown by Professor Amit Mahajan also in his previous lecture. And there are lots of literature evidence supporting my point, right from Gross from 1986 to E et al. In 2019. We have lots of literature evidence. Of course, there are few modifications time and again which have been developed just to how to modify this incision. Now, for any treatment of any complex fracture, you should have an adequate exposure, and this is my point for this. With this approach, we generally get an adequate exposure, and with the same approach, we can expose the medial orbital wall as well as the nasofrontal suture very well. No surgery is scarless actually. This will give a scar, but the scar is hidden in mostly in the hairline. So excellent aesthetics. And of course, sometimes we also have to harvest a Carvelia graft. So the access to the parietal bone to harvest the dorsal strut graft can be done via the same approach. This gives minimal post-op complications. Complications can be managed if you design our incision meticulously. This is just to demonstrate. See, most of these fractures would not come as classic FNOE. It would also have other fractures associated. So we generally can have an excellent exposure and control over all the fractured segments. We can also go about the medial orbital wall, the roof of the nose, and then, of course, good post-operative results and superior aesthetics with one single approach. And the need for calvarial bone graft, as I was emphasizing previously, can be done via the same incision. So all in all, I'm mostly a bicoronal guy who will like to have this approach mostly in these sort of fractures. Over to you, Yash.
Thanks, Imran. And I would like to now call Girish, who's going to vouch for local incisions and lacerations.
Next slide.
So, well, the literature has documented many more numerous local incisions, and even apart from that, local incisions, we have existing laceration to approach. In fact, local incision has got an innumerable incision, more than 15 incisions. To approach this NOE fractures. Second, the condylar fractures which boast around some 6 to 8 incisions. So the advantage of, since we are all aware of the vertical incision, local incisions, I don't want to go in detail about each incisions. And this is a slide which is showing non-skin incisions, where you can use a transcaruncular or precaruncular incisions to approach, especially the medial canthal ligaments. The main advantage of local incision is a better, since the incision is placed just right above the fractures or very near to the fracture fragments, there will be a better visibility of fracture fragments and a greater accessibility to fix the fractures, since the incision is placed right above the fracture, as I mentioned. So, and also local incisions, sometimes is counterpart to the coronal incisions. What happens? The coronal incisions gives a better visibility to see the fracture fragments, but while fixing the fractures, especially because the coronal incision, practically speaking, to reflect the flap inferior to the nasofrontal sutures is very difficult. So while fixation of the fractures, or you want to pass down, or fixation with the wires, is very difficult in coronal approach, what I personally feel, and even the literature has documented that. So, and apart from all these complications, the coronal incisions has got literature has documented more than 10 to 12% of, particularly the frontal branch of facial nerve, motor nerve injury, and even the sensory nerve, supratrochlear and supraorbital sensory nerve injuries, which is caused aresthesia of the the scalp and the forehead. So both the complications has been not reported in the local incisions. So, and apart from all these complications, coronal approach, what I feel is a time consuming, is a long surgical scars and extensive bleeding, especially in acute trauma cases where there's loss of blood. So you can't approach a coronal incisions to, since it's a extensive bleeding occurs with the coronal approach. And also a risk of alopecia, always there will be a risk of alopecia will be there, and a longer duration of hospital stay. See, this is a slide which is showing to address the simple NOE fracture, which is not involving a frontal bone. I think it will become invasive to approach through coronal incisions. So what we can do is a simple inch incision or a civil incision, just to 2 to 3 centimeters. We can correct the NOE and minimize the scars by higher finer suturing techniques. As I mentioned in the earlier slide, it's difficult to detect the flap. Inferior nasolabial suture at times causes difficulty for fixations.
Okay.
And these are the couple of cases where we can see the existing lacerations. What the literature shows, since the midface is a very weakened part, NOE usually occurs with a direct impact. So most of the NOE fractures will be associated with the existing laceration, more than 60 to 65% of the cases. So if there is any existing laceration, that's a gold standard.
Can you go back to the previous slide?
Yeah. To conclude, I just have one conclusion. I just wanted to mention one more thing. Many of my, when I was speaking to my senior, junior colleagues, they were more worried about the scar over through local incisions. See, with the development of fine suture needle techniques and even a better armamentarium like for magnifiers and the loop, I think we can minimize the scars. So what I feel is a simple, a small hole, it can sink a big ship. So the reverse analogy of the same, when we consider for this debate session, a reverse analogy of the same, if I conclude for this debate session, I think we can go for a local existing, local incisions or existing lacerations so that we can minimize the complications associated with coronal incisions and makes the life easier for both surgeons and the patient.
I would like to call for rebuttal at this point between the coronal approach guys and the local incisions.
I will just quote Larry Sargent, 2007. There is unfettered, access required to address FNOE, and that is where I'll end it. I don't want any scars on my patient's face because there is, I'll talk through my presentation next. There is enough literature to show that aesthetics is number one and function comes second in the eyes of the patient.
So what if you have lacerations on the patient's face?
Then it's a compulsive thing then. It's a compulsive thing then. I'm not introducing a new laceration. I'm not introducing an incision there. What the patient has come with trauma,
But then most of the patients with NOE fractures eventually have overlying lacerations. I think that is something that we need to take advantage of. Most of them, in fact, most of the cases which Yash projected during the introduction, all of them in fact had existing laceration.
That's the literature documents that, because in the midface, NOE is the weakest part. So until unless there is a direct impact to the nasoorbital structure, there won't be any comminuted fracture of NOE. So always 60 to 65% of the cases usually involved with existing lacerations. So NOE, I think if there is existing laceration, no other things, it's a gold standard, go through a laceration, lacerated wound.
Also one additional point that I would like to add here. See, if you want to do a canthoplasty procedure concomitantly, I think the local incisions are the most ideal. You cannot manage with a coronal incision. I think that is very important.
Did you say you cannot manage
the laceration
canthopexy?
should be actually big enough to produce that much amount of exposure. Not necessarily we have a laceration big enough for a fracture or exposing all the fracture. Of course, we can combine it with the mid-facial degloving incision. Again, it's a scarless thing. Entire thing is intraoral. So again, as Dr. Rohit just rightly said, we require an unfettered access and a good control over all.
Larry Sargent said that, I didn't say that.
You quoted it.
Okay, that brings us to the next point of contention between our teammates, canthopexy, ipsilateral versus contralateral.
Okay, thanks, Yash. With due respect to the proponents of transnasal canthopexy, I would like to begin presenting my points by quoting a master surgeon. And yes, this is what he has to say about transnasal canthopexy. Though effective, this procedure is time-consuming. At times, it is frustrating. Now, these are the words of Vandermeulen, the man who designed facial bipartition. Then people like me are bound to have more hurdles. Yes, I do admit that this procedure is technically difficult and technique sensitive. Additionally, when you perform these procedures, there is a possibility of inducing damage to the opposite nasal bone, intranasal hemorrhage, and most importantly, there is but you cannot miss this, potential risk of injuring the contralateral orbital structures and the anterior cranial fossa. Additionally, yes, this is a major concern. It can cause pressure ulcers on the nasal skin. So I think it is perfectly justified to think of an effective alternative, and that would be ipsilateral canthopexy. Why not? See, these are the people I have quoted from 1992. There's an army of surgeons who also seem to think so. I have quoted from 1992 to 2022. And there are many more names which I have not added here, and I'm very, very sure that so many out there among the audience also think so. So the rationale behind ipsilateral canthopexy is this. You address the problem where it lies, without injury to adjacent normal tissues, while at the same time creating the ideal, the much emphasized vector posterior-superior to the posterior lacrimal crest. Literature mentions a lot of techniques, right from Cohen et al. Using the frontoglobular area for wire fixation, and Quinn et al. Using a medially placed plate or screw to gain anchorage for the medial canthal tendon, and Chu et al. Fixing a screw in the medial wall of the orbit, the nasomaxillary process, and Timoni et al. Using the transcutaneous suturing to periorbita. Many more techniques, unitransnasal technique by Turgot, and anterior fixation of cantilevered mini plates by Shore et al. And Engelstadt's transcaruncular barb and mini plate technique. And all of them have proclaimed good clinical outcomes. Now, to the million-dollar question. Which technique is better? Do we have any comparative study? Yes, if you look up literature, there is one. I think, in fact, this is the only one that I could come up with. This study is a biomechanical one, which compares transnasal wiring with medial canthal tendon fixed to a screw on the medial surface of the orbit and the Mitec anchor. And the results are quite surprising. If you notice, though all three of them give reasonably good strength, look at the holding strength. It is the maximum for the Mitec anchor, followed by MCT, which is fixed to the anchor to the screw in the medial orbit. And finally is your transnasal wiring. And this has been attributed to the highest elastic deformation that you usually find in transnasal wiring because of the wire elongation. Now that is something that we need to think about. Having said that, there are many more advantages to transnasal ipsilateral canthopexy. It offers a direct and quick access. It permits easier identification of the medial canthal tendon. And if you want to do a concomitant canthoplasty, yes, it helps very much. It also enables simultaneous surgery to the lacrimal apparatus. Quite often we get to see such cases. And this is very important. In secondary cases, it facilitates removal of scarring or fibrosis in the subcutaneous layer. And these are some of the cases. Now this patient presented with fracture of the ZMC, orbit, and NOE type 3. And this is the patient after the primary management 6 weeks later. You can see the increased canthal distance on the left side. Now definitive management was done by using ORIF of all the mentioned fractures, and ipsilateral canthopexy was done by securing a stainless steel wire to a plate adapted medial to the wall, on the medial orbital wall. And you can see the positioning of the plate also providing the ideal vector. The plate has been taken posterior and superior to the lacrimal crest. And you can see the postoperative result. The canthal distance is equal on both sides from the midline. This is another case of Dr. Girish. He's tried to anchor the medial canthal tendon to the medial wall by drilling holes. This is another case where you can see that the patient has altered asymmetry of the medial canthal tendon. Again, L plate has been used to anchor the medial canthal tendon, and a Z-plasty has been done to define the medial canthal angle, and that's the postoperative result. This is another case of mine where a 7-month-old fracture. I have tried to use the Timoni's technique, YV incision, canthal repositioning, and that's the post-op picture that you see. So yes, I feel ipsilateral canthopexy is ideal for isolated NOE fractures, best for secondaries. It offers quick and direct approach with good biomechanical strength, and most importantly, it negates complications of transnasal wiring.
Transnasal, Rohit. Thank you, Venal. Thank you for that. We will come with the rebuttals later.
You want me to rebut?
We can rebut after your presentation.
Okay. So the points of contention here are long time taken. Yes. So all good things take time. The second point of contention is the holding strength. Okay. So because you take it through the nasal bone or through the frontonasal process, of course, there will be always a risk of collapse, but then you need to do it the way it's described. Okay. Let me go one by one. Lawar has stated this in the, in 2010, that aesthetics is the more important concern with patients come up with when they have, things like telecanthus. AO surgery reference, we all follow well. A transnasal canthopexy must be performed, and that's the most important aspect, is that the medial and posterior repositioning of the medial canthal ligament be done. And this is ideally done more so by taking the wire 5 mm posterior and above the posterior lacrimal crest, getting it onto the other side. And actually, I would say we are just underplaying the significance of a canthopexy here when we say that it's a transnasal pexy, because I believe it's a transethmoidal pexy more so, because you're taking it through the lamina papracia and coming onto the other side, although there are other ways to do it. But this important fact stated by AO cannot be, underestimated. Well, these are the different ways that we are all aware of doing it. You can take it through, as most people do. You can take it through and turn it around from the other medial by dissecting the medial orbital wall periosteum and taking it over to the frontoglobular region. There are other ways, but the most important thing is that the wires must be placed at the MCT attachment position of the central bony fragment as related to the anterior posterior as well as the superior inferior positions. Failure to accurately complete this step can result in flaring of the medial orbital bony segments and an anesthetic result. And for people who are really scared of doing this, I just made a small video for all my friends. Can we play that video, please? This is a video which shows transilluminated skull, and you can see how clearly there's a distinction of the frontoethmoidal suture there. You can see the ALC and the anterior ethmoidal foramen, and you can very clearly see that there's a good rigid, a small piece of bone there which is dependable actually to pass your transnasal wire or the transethmoidal wire, I'd say. So, of course, there has been caution in this region because people say that it's difficult. The difficulty is that you have to avoid the intracranial region and the skull base and the encroachment on that area. But if you carefully see this video, you realize that that area is identifiable with experience. And I think you should do the difficult things. It will take some time, but I think you should do it. It's worth it. Well, there is more literature on transnasal wiring when you, go into the ophthalmology literature, and aiming the wire slightly superiorly towards the contralateral glabular side can help it, creating the proper vector and allowing more purchase to support the wire. So if you don't want to do it beneath the base of the skull, you can still do it to the frontoglobular fixation. And secondary telecanthus correction, of course, we always have to take it the other side because there's a lot of fibrosis also which is controlling things on the ipsilateral side. So you need to do overcorrect it, and slight amount of overcorrection is completely warranted. A 5-year prospective study of more than 1,000 cases demonstrated that NOE fractures present the highest rate of complications when not done adequately the first time. Primarily the injury has to be corrected correctly so that you don't get a lot of, I'll go through this small case. You can see epicanthus inversus. You can see that there is a, of course, telecanthus. And can we play this video? You need to sometimes actually refracture the bones. And once you are done with that, you may realize that most of these cases, although literature says many times you'll have a type 1, but at times you realize that despite mobilizing it, you don't get the medial canthal correction. And you do have to actually go ahead and look for the medial canthal ligament, which is very difficult to identify. And once you've found it, I would never take the risk of doing it ipsilateral. And I think we must go contralateral, keeping in mind these complications. But ultimately, you have ways of getting it to the other side, you can invent, you can put different types of plates, you can take the wire all the way the other side by using frontoglobular fixation, which is relatively easier, less technically difficult, and does not have the risk of your skull base injury as well. So how has the epicanthus inversus disappeared? And you can, of course, appreciate the vector there. I would leave this case for the moderator to discuss if she may want to. Otherwise, that will be all from my end.
So, thank you, Rohit. Rebuttals?
My only contention is the possible injury to the adjacent normal structures. And what I feel is if you can provide the same vector that what you speak of when you do a transnasal canthopexy, why not? Why not manage with something which is much simpler and which is going to take less time? Especially even about the approach, when you have superficial lacerations which are directly over the canthal tendon, I think it is much easier to address it through the laceration.
How would you do this ipsilateral? This one.
For this case?
Yeah.
Yes, can be managed, yes.
Ipsilateral with fibrosis?
Yes, a few of the cases which I showed are also
that's
malunited cases, yes. A few of the cases which I've shown earlier also are malunited cases which can be managed. If you have adequate bone superiorly to position to cantilever your plate, yes, you can take it posterior and superior.
Then we need to work on a meta-analysis between you and me.
Yes, definitely. Have to come up with a study. Like I said before, there are not comparative studies. That is a big lacuna in literature. Not many studies which compare both the techniques with similar cases. That's very important.
Right. How, when you do unilateral canthopexy, in a case where there is loss of medial orbital wall, how will you go about achieving a unilateral pexy?
I'm sorry?
When you have loss of the medial orbital wall, what will be your mode of reconstruction? Because you need to have a stable segment there for you
That's
to
right.
anchor
So
it, right?
and you fix a plate on the frontal process. Or some surgeons have even tried fixing a plate on the nasomaxillary process if that is intact. It is not intact. Then you take it from frontal process.
Is there any point of time that you would consider going contralateral, or would you always go ipsilateral?
Whenever possible, ipsilateral. Yes.
So there was case 3 that I showed at the start of it, which was a quietly badly mangled case. What would have been your choice of doing a pexy?
The last case,
yes.
The one which needed the coronal approach.
Yes.
Yeah, there I think transnasal would be possible because anyway you're going to expose the area, you're going to see bilaterally. Then I think it is only ideal that you use a transnasal canthopexy.
Girish, this is for you. When you're going through the laceration, how do you ensure that you don't strip the canthus off the bone in the process of you exploring the fracture? Because then you're actually converting attached medial canthus and you're converting it to a type 3. So how do you ensure that?
See, in a case of existing lacerated wound, the advantages is direct. We can visualize the fragments and the attachment. Even the small minor fragments, fracture fragments also can identify since it's a direct visibility.
Correct.
So,
but what in the process of you stripping and exposing the bone fragments, how do you ensure that you don't strip the canthus off?
In fact, Young and Rice have clearly said this, that in NOE type 2 and type 3, you have this issue of, inadvertently stripping off the medial canthus. And with so many muscular things, you have the Horner's muscle, you have the medial canthal muscle, you need eyes of probably, I don't know, you need Shivji's third eye probably to see exactly what structure is what. Are you doing it under magnification? Because I do all my cases under 4x. And I feel that still, I have those, identification issues if I have very limited access. I want to see the area, unfettered access.
Yeah, say something. This is something which I emphasized much earlier also. In a case as this, when you have a malunited fracture, again, I want to stress here that there's a lot of fibrosis. How are you going to address the fibrosis through a coronal
Vedil, my question was on a primary case, not a secondary case. Yeah, my question was on a primary case.
Right. Yeah.
How would you ensure that you don't strip the fragment off?
Think even if you have stripped the metacarpal ligament from the fracture fragments, we have clinically we can do a Bowstring's test where we can identify a couple of structures, soft tissue attachment till we get the ligament and try to create a tension, and clinically we can palpate the ligament. So identify it clinically because this is a direct visibility in an exited laceration. I think it's not so difficult to identify.
Using a
posterior
magnification will actually help you a lot. I've been doing this lately, so it helps you a lot with your adding magnification to your armamentarium.
Okay, so any more points that you want to say?
How would you identify a detached tendon from the coronal aspect? That's what I'm asking.
How do you identify
How do you identify a detached tendon from the coronal aspect? You will have
do
to
it
come
better than doing it through a small laceration.
from the coronal side. You will not have the visibility or the approach to.
Can I go back to my video? There was a video which I didn't play because of the time lag. Just a minute. Yeah, this one. This is exactly what we are doing here. Can you play this, please?
Yeah.
You can actually figure out. I mean, I have my assistant standing in front and I am at the back. I'm pulling that area. I'm identifying a white strand, if possible, a white fibrous thing, the maximum that you get, and this was a residual one. So difficult, really difficult to find that. But there is access. I mean, you can see there is better access. This is exactly what we are doing, and you'll see that the wire would come onto the opposite side. I don't know whether we are able to appreciate that. Yes, you can see, yeah, that's the wire coming onto the opposite side. It's hung with you have a 3/0 suture passing through the tendon once you identify it, and then you pass a 28 or a 30 gauge wire, pull it to the opposite side. Your assistant checks for the vector in front. You'd have to depend on your assistants. All by myself is not possible.
Okay, let's move on to the next aspect of contention here. See, this point of contention is not whether this needs to be done or not. It is how many of us actually do it when we are doing NOEs. The nose and the septum, primary versus secondary. Girish?
So I would always prefer to go for secondary, since if you do primary, addressing the primarily with a bone graft, what happens? There will be a over-projected graft leading to higher nasopharyngeal angle. You can see clearly. You can see in the first slide, which is borrowed from Craig Brailfels in his textbook, and also on the last presentation, Dr. Kannan also already highlighted about that. By doing a primary nose, there are high chances of over-projected graft, which leads to very unpleasant or anesthetic results. Again, it needs a secondary intervention to correct that. So, and also in cases of existing lacerations with a loss of soft tissue, even if you do a primary graft, there will be more chances of graft extrusion can occur. If there is no much of comminuted fracture involving, so even identify a small fracture fragments and get into a place with using a transosseous wiring. That's known as nasal cap. Nasal cap in the sense, I'm not mentioning about a nasal splint or something. Get into a shape, a V shape, an inverted V shape of lateral wall of both sides of a nasal bone. Even fix that identify smaller fragments, fix it with the wires, get into a normal nasal cap, which can definitely the good results post-op, where we can avoid a nasal bone grafting, or even sometimes it prevents a secondary grafting also. You see pre-op and post-op, the yellow marks, where we can, arrow marks shows a clear elevation in the nasal bridge. And in cases of some extensive multi-organ injuries, it requires a multi-specialty approach to prevent any longer duration. So it's better to avoid a primary nose and go for a secondary construction. And in cases of CSF rhinorrhea cases or any midcranial fractures, what happens? You can't put a nasal splint for those type of cases when you do a primary graft or a primary septum. So it's contraindicated, in fact. So even if you do a septum, if you address primarily septum and a bone graft, and if you have failed to put an intranasal pack properly, I don't think it will end up with a failure. So rather doing that, wait for it, identify the defect properly. After 3 to 6 months, go for it. So this is a case I can show you secondarily, which has been done through a kind of a rhinoplasty incision, intracartilaginous approach, where we got a good nasopharyngeal angle and elevated, the saddle nose deformity has been corrected. So when we can secondarily, wait for it, identify, wait for the 3 to 6 months, identify the defect, then plan properly, because the end of the day is aesthetics. So better not to do primarily, what I personally feel, and even some literature has been documented that.
Venal will vouch for why primary reconstruction of the nose has to be done.
Okay, I do understand Girish's concern, but to begin with, I want to say that, I want to emphasize rather that nasal reconstruction does not refer to reconstruction of the dorsum alone, like what is usually done. It also refers to the reconstruction of the septum. Now, the logic behind primary reconstruction of the nose is early restoration of not just the aesthetics, but also function, which is breathing. And then we move on to the most important aspect, which is avoiding increased scarring and soft tissue collapse. It is very, very important. Now, to elaborate on these facts, poor aesthetics in NOE fractures is because of, as you can see, increased intercanthal distance, depressed midface, flared alar width, and a pig snout profile or a saddle nose deformity. While impaired breathing can arise because of all these reasons: deviation of septum, collapsed nasal valve, nasal bone displacement, collapsed dorsum, and even septal hematoma. Now, shouldn't we look into all these things? It's very important. Now, to explain to you all what complexity that soft tissue scarring can actually do to a patient, I want you all to have a look at one of my patients. My experience with this patient, unfortunately, I could not operate on him immediately because of many reasons from the patient's side. Now look at the patient in the immediate post-trauma phase. That's how he presented to us. In just 2 weeks, you can see the depressed midface and the flared alar width. It becomes worse in 7 months. And that's the profile view showing the saddle nose deformity. Again, the collapse of the nasal pyramid in 7 months. So any day, I'm sure most of us would want to manage a patient as this on the left side than a patient on the right side with loads of scarring. Now that is, even if you operated on such patients, the results are going to be suboptimal. That is one thing we must always remember. Soft tissue scarring is very, very difficult to manage. How much of a graft you insert, you need space, first of all, to insert your grafts. Now the logic behind primary reconstruction of septum, let's understand that septum is akin to a tent pole. So when you have loss of septal support, there is loss of projection, deviation of nose, as what is shown here, and airway obstruction. So literature says that up to 30 to 40% of failure rate has been observed whenever these fractures have been managed by close method, necessitating a secondary septorhinoplasty. Please remember, septal repositioning is the 6th tenet in sequencing of NOE fractures by Edelis. Now this is one of my patients where you can see the septal deviation managed by with post-traumatic difficulty in breathing, also managed by septoplasty and repositioning of the septum to the ANS. The post-surgery improvement in aesthetics and breathing was quite appreciable. Now, evaluation of the septum in NOE fractures is also important for yet another reason. Park et al. Has given a very nice algorithm to use the degree of septal injury to choose the graft that you would need for dorsal augmentation. So according to them, they say, my saddle nose deformity with good septal support, you could use fascia, crushed cartilage, or Turkish delight with dice cartilage. When the saddle nose is severe with poor septal support, you need to have middle wall reconstruction, and that is usually done by a strut graft. And yes, these are the reservations towards primary grafting. By many surgeons, the fears are many because of the chance of exposure, tendency for resorption, possibility of infection, and most importantly, doubts about the graft uptake. Now, all these fears can be managed with the reassuring words of Gruss. I quote him verbatim. Firstly, he says, loss of distal nasal support can be corrected only by primary grafting. He goes on to say that bone grafts will maintain soft tissue expansion and projection even if the segments become exposed, or even if partial resorption occurs. It's still okay, you have good soft tissue cover. And he advocates split rib grafts because they have exceptional ability to survive even if portions of the graft are exposed to air. What more can you ask for? And finally, he sums it up saying, the risk of possible graft exposure must not preclude their use. Amen to that. So this is, I just want to show you what difference dorsal augmentation can do to all these patients. Now this is a patient with open reduction internal fixation and NOE fracture. But see, look at the change in aesthetics when dorsal augmentation is done. Why should you deny a patient of this early restoration? Please understand, more the nasal dorsum projects anteriorly, the less the intercanthal distance appears. This is an optical illusion, but still we need to make use of that. Another case, again ORIF with canthopexy, but look at the change in aesthetics when you do a dorsal augmentation. In conclusion, I would like to say that primary reconstruction is absolutely essential for breathing as well as for aesthetics and to maintain soft tissue drape. Address the septum and always choose the graft based on the defect.
Yeah, one major reservation against primary reconstruction would be the soft tissue availability. Like if the soft tissue at the time of primary is not available or avulsed because of any injury or that time I have a serious reservations which will actually not allow me to do a primary reconstruction.
Primary reconstruction is adding more to the dorsum. It's correction of the pseudotelecanthus that is coming from the ipsilateral correction maybe. So if you do a contralateral correction, you may not need to add it.
Let's have our debaters getting active a little.
And in cases of if there is a comminuted fracture involving the frontal nasal nasal process, nasal bone, there won't be any base, there won't be any difference. So how will you primary graft?
But I will tell you what, again, we are discussing only about the aesthetic part of it. Where is the functional part of it? When you prevent a collapsed dorsum, you are adding more to the airway also. I think that is very important, that's a primary concern that we need to address.
Right, so the proponents for secondary are going to change now? Not at all. No?
We have evidence from, did you quote Zhang? Did you quote Zhang in 2005? 13, out of 29 cases, 13 had them. So, I mean, if we can do it comfortably secondarily, there is no need to introduce a free graft in a potentially infected site. How many times in surgery do we do that?
How do you maintain the soft tissue not contracting over that loss of bone support? Because I think as Venil actually said, it's quite difficult to overcome the scar tissue if you want to do a secondary procedure. So what would you do to prevent that from happening?
I do agree with your point completely, but the point that I want to push in is when you're doing a bicoronal access, there is always good amount of soft tissue variability that you can play around with because you have a huge incision, you can actually buy tissue from that flap itself. You don't specifically need to add tissue. We've never done that. We have never needed to add tissue there. And if there's a collapsed bridge, you can comfortably put a graft at that point. Cantilevered, that's not new to the literature. It's a very old school technique of putting a rib on the, a cantilevered rib to get the dorsum right.
Why wouldn't you want to take a calvarial graft, Rohit?
You can do. I said so, age-old technique of using the rib there. I didn't say we can't do a parallel.
Okay, but you would do it. Yeah. So, Venil, when you, I noticed many of your cases are secondary and you don't go coronal, you go through local incisions. What would be your choice of graft for the nose?
Like I mentioned in the presentation, yes, I prefer a morsel like dice cartilage. And only in absolutely essential cases, I go for a strut graft, yes.
Okay. So you would always go for the morselized cartilage?
Morselized.
Okay.
Because literature also says that the resorption of cartilage is much, warpage of cartilage is much lesser when the cartilage is diced. There is proven literature.
So in a primary scenario, if you had to do nasal dorsal grafting, what would your choice be then, if you're going through the laceration alone?
If I'm going through the laceration?
If you have to put in the nasal bones back, if they're comminuted, what bone would you choose?
If a coronal approach being used or the frontal bone is exposed, then a calvarial graft.
If not?
If not, a rib. You can, because you get lots of, when you use dice cartilage, you get lots of cartilage with, yes.
So she will build it up with that, okay.
I just wanted to ask Dr. Elevenil one. If there is an existing laceration with loss of tissue, so how will you overcome from that? When you do a primary grafting?
Yes, the results are going to be a little suboptimal, but then that is what is advocated by GRUS. Whatever you can mobilize from the side, the soft tissue, use the elasticity of the skin, mobilize towards the center and try to, or even the, coronal incision.
Again, we are going towards coronal incision. Yeah, again, we are going towards coronal incision. Yes.
It is.
So this is why at the start I introduced
I mentioned the local first. I mentioned the local first.
Yes, yes.
Because the skin is more lax. That is a big advantage.
Literature evidence also suggests rib is an excellent graft for, it's an excellent graft material. So I would personally go with rib.
Rib. Okay. Any more? Don't fight, obviously, but yeah, you can agree to disagree. But you can largely see that the debaters are also in consensus because trauma is never one specific technique for all cases. You need to adapt according to the kind of cases that present to you. So to summarize, we can see that existing lacerations can be used very effectively in indicated cases, and those that need or have extensive injuries need to have an extended approach. Both ipsilateral or contralateral canthopexy can give good results when they're used adequately and appropriately. So the idea is to get your vector correct. It should be posterior and superior to the posterior lacrimal crest. So if you're able to achieve that, then it is good enough. And sometimes combination approaches, which means you have to use local incisions together with your coronal approaches, you have to do a canthopexy, and you have to always consider primary nasal bone grafting when needed in order to restore optimal contour and function. And as you can see, Venil was also emphasizing on addressing the septum primary as best as possible to prevent the secondary deformities. Thank you all. That's all for night, and this is just to invite
from the organizing team of Delhi and Haryana chapters of AOMSI, we would extend a warm welcome. We welcome you all next year to Delhi and see you. Definitely we expect a good audience there. We will have a great scientific program. So we would like to extend a warm welcome to Delhi next year. Thank you.
Thank you all. Thank you all for sitting through this. When we started discussions on the debate, my team members were quite uncomfortable to say that no, I cannot vouch for only this or vouch for only that. So we try to bring in scenarios and identify techniques that they would do differently so that you can actually have an idea that it can be addressed this way also. Right. Thank you so much for this.
It was a wonderful.
The speakers. First, Dr. Yashwini Thilikat ma'am, please come on the stage. Dr. Ilavanil ma'am. Dr. Girish sir. Dr. Dhiravani sir to please come on the stage to facilitate our chairpersons. Call Dr. Ashok Dabe sir and Dr. B.M. Srivastav sir to please come on the stage.
Ladies and gentlemen, and welcome to the 46th AMSI National Conference Indore. I'm sure you had a great time with all the stalwart speakers from different parts of the world here. We'll have our next session, the CMF Master's Stroke session. So I would request all of you to please be seated. Sorry for the inconvenience. Just 2 minutes, we'll be starting our next session for the day. Thank you very much.
Is the well-known Dr. Gopal Krishnan. Dr. Gopal Krishnan is from Dharwad. He has been professor, head of the department there, a very skilled and mature surgeon, and he is holding a high post in AO. He is a great friendly person. Go ahead, Gopal.
Term revisited purposely. This is going to be a milder version, an unbridged version an unplugged version of managing the medial canthal ligament. There has been a lot of debate about that, but I'm an old timer and I prefer it on the opposite side. So MCL has to be handled in two status. One is the type 2 sometimes, and definitely in type 3 fractures, Markowitz fractures. And as the previous speaker alluded, the famous dictum by Ed Ellis is going to be the next speaker. There is a sequence to managing the the NOE fractures. There's always a method to madness, and this is the sequence that has been recommended, and I've been practicing it for the past many years. And one of the most important aspects in this sequencing is management of the medial canthal ligament, and which is what I'm going to spend the next 15 minutes or so explaining. So if you look at the literature, literature can be quoted for you and against you like the previous speakers did. Most often than not, you don't want to have a scar on your face because, as we all know, an NOE fracture is basically a functional, an aesthetic problem and not a functional problem. And so you would rather want to have a coronal approach to hide the scar and a Lynch incision to identify the medial canthal ligament. So the most common approach for identifying the medial canthal ligament is a coronal flap plus or minus a Lynch incision. This is a cadaver demonstration to show after detaching the medial canthal ligament, you can have a lot of movement. And as is example of this patient, you have a complete detachment of the medial canthal ligament. The almond-shaped eye that you see on the left side is completely changed and rounded about, and that is where you know that the medial canthal ligament is completely detached. So to identify this, you want to use a Lynch incision. And this is a video to demonstrate the Lynch incision, and a small incision is made about 1 centimeter in and around where the medial canthal ligament is attached, and through the skin you approach the underlying tissues, identify the medial canthal ligament and tag it with a suture, and that is what is being done in this particular video. And so that's what is here. The demonstration on the figurative demonstration shows the engagement of the medial canthal ligament with a suture. And the next part of the video will demonstrate that. That is the suture that takes the medial canthal ligament. And it's important to realize that you need both a coronal flap and a Lynch incision to manage the medial canthal ligament. So you remove the needle through the coronal flap and engage the medial canthal ligament with a suture. The next component is to engage to secure the medial canthal ligament. If you look at the anatomy of the medial canthal ligament, you have an anterior limb, you have a posterior limb, and the ideal position for your medial canthal ligament should be as posteriorly as possible and as superiorly as possible behind the posterior lacrimal, the crest. So what you can see in this particular picture is the anterior lacrimal crest and the posterior lacrimal crest, and you are securing the medial canthal ligament should be posterior to the posterior canthal crest, posterior lacrimal crest. And to do this, it's impossible to do it in the same side. You have to secure it to the opposite side, and that is the logic behind transnasal canthopexy. Another thing that we need to keep in mind is the position of securing this ligament is as posteriorly as possible. And if you do a direct fixation on the same side, you will never be able to go behind the posterior lacrimal crest, and that is the reason why you need to do a transnasal canthopexy. So this video demonstrates the position where you want to fix the position where you want to have your medial canthal ligament after securing it. So the instrument shows where the anterior crassimal ligament is, and you need to go behind that. And to secure it properly and securely, you need to tag it to a plate. So what the surgeon does is to pre-bend a plate and use the whole of the plate to secure the medial canthal ligament, pass it through the plate and take it to the opposite side. So that is a video demonstrating a plate being bent and fixation of this plate onto the area which is already marked, and then you try to drill a hole from the opposite side and pass the wire bearing the medial canthal ligament through the plate to the opposite side. And that's a demonstration of the drill coming from the opposite side, securing the plate, and then the medial canthal ligament is passed through this and taken across. We'll see that in a minute how it is being done. So this is a drill. You use a cannula and go as posteriorly as possible, and as Rohit mentioned, you are going through the ethmoids, you are not going through the nasal bones. And you can see that the drill comes out through the area where we marked it, and then the wire engaging the medial canthal ligament goes through this hole to the opposite side. So you use a cannula, the cannula goes from the opposite side to the affected side, and once
is Professor Dr. Edward Ellis. In 1992, please welcome Professor Dr. Edward Ellis. In 1992, I had an opportunity to go to Dallas, my first trip to US, and make a presentation at Parkland Hospital. In those days of slides, everything was set up. It was a gathering of residents, and Walker, the great Dr. Walker, was in audience, and I was thrilled because I was getting a chance to speak to all of them. I was about to start talking, and suddenly there was a spark, and the bulb from the projector, it just went off. It fused. I said, gone is my chance to speak to these guys. Then suddenly one sharp-nosed young man came, he bent down, picked up a bulb, replaced it on the projector and told me, go on. And that was Dr. Edward Ellis. Dr. Edward Ellis was on staff at Parkland. We have heard him at many times. All the students, I think, remember for his chapters from his books and the various articles and his practical approaches. Welcome, Professor Edward Ellis. The stage is all yours.
Thank you very much. Portion of zygomatico-orbital fractures. And so let me start with just, first of all, explaining that a zygomatic maxillary fracture, you have to understand the lines of the fracture to adequately treat them. And the key to these fractures is understanding the inferior orbital fissure, because from the inferior orbital fissure, there are 3 lines of fracture that emanate out. First one comes anteriorly over the maxillary bone, the orbital plate of the maxilla. Then it goes over the face of the maxilla, down under the zygomatico-maxillary buttress. Another line that emanates from the fissure is up the lateral wall of the orbit along the sphenozygomatic area, and then it comes out across the frontozygomatic area. And then, of course, underneath the infratemporal area, the inferior orbital fissure is another line of fracture that goes along the posterior to join the one from the anterior region. And then lastly, of course, if it's a complete zygomatical maxillary fracture, you have to have fractures somewhere along the zygomatic arch. And that can be a single fracture or a triple fracture with 2 free pieces. So those are the classic lines of fracture in a zygomatic complex fracture. But the orbital portion is almost always involved. Almost all zygomatic fractures have an orbital fracture associated with them. And the question is, how important are they? Some are very important, some are not. There are many names we use for these fractures, and I think probably the most descriptive would be a zygomatico-orbital fracture, because most of the orbital fractures we treat are zygomatic fractures. They are more common than isolated internal pure blowout fractures. So don't forget the orbital component of the zygoma. Now, one of the things that I've learned over the years in treating patients is that the amount of internal orbital disruption from a zygoma fracture is usually less severe than when you're dealing with pure blowout fractures. The other thing that I've noticed is that the amount of internal orbital disruption with a zygoma fracture is not proportional to the displacement of the zygoma. Some minimally displaced zygoma fractures have very large orbital fractures, and conversely, some grossly displaced zygomatic fractures have very small internal orbital defects. So when you have a patient, you must study your radiographs very carefully, because those CT scans will give you an idea of whether or not you need to do much with the internal orbit. Let me show you a case with what I would call a severe disruption of the zygoma. Lots of displacement, as you see here, and yet look at the internal orbit. It's not so bad. So even though the zygoma is grossly pushed back, the orbital component is minor. And so this case was treated with 3-point fixation and 3-point exposure, but the inside the orbit, it was really a very minor amount of disruption. to be able to treat this. So again, always study your CT scans because they're the things that will tell you how much intervention is necessary. Here's a case of a minimally displaced zygoma fracture, very small displacement, and yet look at the amount of internal orbital disruption this one has. So again, they're not always the same. So in this case, we had to do a very large internal orbital reconstruction, in this case with bone, to get that outcome. All right, so a couple of things you have to understand when we talk about orbit. What we're trying to do here is to keep the eye position what it should be. And there are two reasons for globe malposition with a zygoma fracture. One is a malposition of the orbital rims. The other is a malposition of the internal orbital walls. What we're trying to do here is prevent enophthalmos. Now, enophthalmos is mainly caused by an increase in bony orbital volume, not so much soft tissue problems. And the increase in orbital volume can come from one of two things: orbital rim malposition and internal osseous defects of the orbit. So when you have enophthalmos after you've treated a zygoma fracture, it's usually because one of two things happened or both happened: inadequate reduction of the zygoma and inadequate internal orbital reconstruction. One of the things you have to understand about the internal orbit is this: the position of the globe is based upon what the anatomy of the bony structures are behind the equator of the globe. And what you probably have never thought about, but you need to understand, is this: when you take your finger and place it along the lateral aspect of your orbit and you push it onto your ocular globe, you are already halfway along the globe. You're already at the equator of the globe, which means that if you have a zygoma fracture that is laterally displaced, you have greatly increased the orbital volume, because whether you calculate the orbit volume as a cone or a pyramid, it doesn't matter. The important thing to understand is that at the opening here, it's a function, it's a square root. So it's a square. If you increase a little bit laterally, you move the zygoma a little laterally, you've greatly increased the volume because it's a square function. The volume is squared function. So when you have a zygoma that is laterally displaced like this, you have to be sure you adequately move that zygoma back nasally, or you will have a problem like you see here. She's wide here because the zygoma has never been brought in as much as it should, and not surprisingly, she's gained a great amount of orbital volume, so she's got enophthalmos. So that's one reason. If you don't put the zygoma back in the right spot, the orbital rim is no longer in the right spot, you can have a great increase in volume. The other problem is if you don't reconstruct the internal orbit when it needs to be reconstructed. This is a patient that was treated many, many years ago, not by me, but by someone else, and a CT scan was never obtained. They treated this patient using plain radiographs. And with plain radiographs, it's pretty obvious that there's a zygoma fracture, but you really can't see what's going on inside the orbit. So this patient was treated with a 2-point exposure. This is at the pterygomaxillary buttress from a transoral approach and a brow approach, and they got an absolutely perfect reduction of the zygoma. The zygoma is in a perfect position, but look at the severe enophthalmos this patient has been left with. So that's when I saw the patient and I took a CT scan, and you can see the issue. The zygoma is in a great spot. Everything looks pretty good, but look at this internal orbit. The medial wall and the floor, this is a 2-wall defect that was never addressed during the surgery. So you always have to study your CT scans to figure out what needs to happen with your surgery. Now the question about zygoma fractures, do all zygoma fractures need to be treated? And the short answer is no. It's obviously based upon all the other things we normally talk about. Is there going to be a cosmetic or functional defect if we don't treat it? And a lot of these don't need to be treated if they're minimally displaced, if the internal orbit is minimally injured. So always study your CTs. Now, why do we treat zygoma fractures? And Gopal said this a few minutes ago. A lot of the reasons that we treat facial fractures, especially in the midface, are because of cosmetic reasons. There aren't many functional problems that come with a zygoma fracture. Certainly if it's displaced to the point where it's interfering with the coronoid process and the patient can't open their mouth, that's a functional issue. Ocular dysfunction, maybe, but that's not very common, even from large orbital fractures. So always think about, why are we operating on these patients? I would submit that most of the reason with a zygoma fracture is for cosmetic reasons. All right? So, what do we know about zygoma fractures? Well, they're not uncommon. We see them all the time. And it's probably the most common orbital fractures that most of us see. They're more common than isolated pure blowout fractures. And the thing that always amazes me is how much treatment varies between different surgeons, or different specialties for that matter. Why should that be? Why should I show you a patient, CT scans, and you and I why do we differ on what treatment we would provide? That's always amazed me, and a lot of that has to do with our training, our experience, what have you. But I think you can be more scientific than that. I actually believe that most of us should be treating these the same. When you treat a zygoma fracture, these are the three most important questions you have to ask yourself and make sure you satisfy before you leave the operating room. If you needed to perform internal orbital reconstruction, did you do that? And did you do it well? Did you put the zygoma in the proper position? And did you properly stabilize it? Those are the three most important questions that you should always ask for. Now, I'm here to talk about the internal orbit. So, a couple of things about this. I believe that you can make the determination about whether or not you need to do internal orbital reconstruction with a zygoma fracture by one of two ways: using your pre-treatment CT scans or your intraoperative CT scans. Both of these, I believe, will let you have the information you need to determine whether or not you need to reconstruct the orbit. Now, I will tell you and I will prove to you that not all zygoma fractures require internal orbital reconstruction. And so we have to figure out which ones do and which ones do not. What's the evidence? Well, I think most of us, you can look at a pre-treatment CT scan and make the decision on whether or not we need to do reconstruction of the orbit. For instance, these are 6 separate patients with zygoma fractures, and I would submit to you that each one of these on the top row requires internal orbital reconstruction. You've got large orbital volume increases, you've got comminution of the orbits, or you've got a lot of prolapsing soft tissues. On the other hand, look at this bottom row. The inferior rectus is still supported on bone. There's not a lot of prolapse of soft tissue in any of these. So I would submit to you that these bottom 3 do not need to have internal orbital reconstruction. And I think I can prove that to you. My criteria for internal orbital reconstruction is to have comminution to the point where the orbit changes shape, like you see here. And or you've got significant soft tissue prolapse down into the sinus. So what happens if you have a zygoma fracture that is displaced downwards, like most of them are? So the zygoma has been pushed down and in. And you look at this orbit and you think, well, that orbit looks pretty good. It looks like if we simply elevate the zygoma into position, that the floor of the orbit should align itself. But what happens if, when we rotate this up, it creates a bigger hole here and the soft tissue prolapses out? Is that possible? If we derotate this, are we going to create a defect through which the orbital soft tissues are going to collapse? What's the evidence? This is an article I did many years ago now by one of my residents, Likith Reddy, right here from Hyderabad, actually. We looked at 65 isolated unilateral zygomatico-orbital fractures where we looked at the pre-treatment CT scans and decided that we do not need to do internal orbital reconstruction. So we treated them without that. and then we looked at their postoperative CT scans to see whether or not we had any problems with the inside of the orbit. Well, 58 of these patients had perfect reductions, 7 were imperfect, but minor imperfections. As far as the internal orbital defect, it did increase slightly from pre-op to post-op, but it was no more medial laterally or AP, but 2 millimeters, which is nothing. Orbital floor aligned very well simply by reducing the zygoma in 59 of those 65 patients. In 6 of them, we had a little bit of inferior displacement, but it was minor. Soft tissue prolapse, we had 2 millimeters in 2 patients, and orbital volume was normal in 56. There was a minor increase in 7, a moderate increase in 1, and 1 had a minimal decrease. Now let me just show you a couple of patients from that study. This is a guy who got hit about 3 weeks ago. He never got treated until now. He shows up and he's got severe depression right here on the right malar. But notice he has no anophthalmos, but look how depressed that is. He's got no problems with ocular motility. All right, and here are CT scans. That's a pretty displaced zygoma fracture, right? That's displaced quite a ways. But look at the internal orbit. The inferior rectus is well supported. There's no prolapse of soft tissue. This is a patient that we decided certainly does not need to have internal orbital reconstruction. We treated this patient with a incision in the pterygomaxillary, or the zygomaticomaxillary buttress. We elevated it, put a couple little bone plates on there, and we were done. This is the postoperative CT showing that the zygoma is perfectly aligned. But most importantly, what's the orbit look like? Well, look at the orbit, how it came together. There was absolutely no reason for me to do internal orbital reconstruction on this patient, okay? And the patient, not surprisingly, has a good outcome, good aesthetics, good ocular motility. Now, this is the patient who had the worst radiographic outcome in that whole study of the 65 people. He's got a left zygoma fracture, and you can see this is really minimally displaced. And if you look at the inside of the orbit, yeah, there's some comminution here, but you don't have a lot of prolapsing soft tissue, maybe a little bit there, not much. So we decided just to treat this guy without internal orbital reconstruction. We used a transoral approach and a upper eyelid approach, 2-point exposure, 2-point fixation. This is the worst result in the whole study, the CT results. That looks pretty good there, but yeah, this looks like there's a little bit of, increase in orbital volume here. Not bad. Looks, a little bit of, the floor is a little bit depressed there, but when you look at the guy post-op, he looks just fine. So my point in this is that you can use your pre-treatment radiographs, CT scans, to make a judgment about whether or not you need to perform internal orbital reconstruction or not. It's very useful to just study your scans and you'll figure that out. You can avoid internal reconstruction in probably 40% of the patients. And it's not just me that's found that. Other people have found the same thing. So, who in here has intraoperative CT capability? Raise your hand. Not too many. Okay. Well, you can do the same thing with intraoperative CT. And let me show you how we used intraoperative CT scans. This is an article that I published a while back looking at only isolated unilateral zygomatico-orbital fractures, and we treated some of them. This is when we first got our CT scanner. We treated some of those with intraoperative CT scans. We treated the others using our pre-treatment CT scans to assess whether or not we needed to do internal orbital reconstruction. And let me just show you when intraoperative CT was not available. So here we're using our pre-treatment CT to decide whether or not we need to reconstruct the orbit. About 35% of them we decided needed to have internal orbital reconstruction. When we had intra-op CT available, it was about the same. We decided 35% of them also needed to have internal orbital reconstruction, which tells me that you can use either your pre-treatment CT scans or an intra-op CT scans to make that decision. Let me show you how we use an intra-op CT scanner. This is a guy with a zygoma fracture. You can see how depressed his malar eminence is here. He's got good extraocular muscle movements, but this is a pretty displaced fracture. Look at up here, how far that's pushed backwards. Look at the zygomatic arch. It's way out, and the malar is pushed way back. But what about the inside of the orbit? Not so bad. I look at these CTs and I say, I am not going to perform internal orbital reconstruction on that patient. But I don't have to make that call now. I can make that intraoperatively because I have an intraoperative CT scanner. So what I do in these cases is simply elevate the fracture, put it in a position that I think it belongs. If I'm not sure, I'll expose usually the zygomatical maxillary buttress, and you can see how well that aligns. Now, at that point, I don't put any bone plates, I simply bring in the scanner. So we bring in the scanner, it takes about 6 minutes to do this whole thing, come over to the console and look at the outcomes. And what you see here is that I did not do a very good job of aligning here or on the zygomatic arch. This area at the buttress looks pretty good, and at the infraorbital rim. So I know that I have to do something else. So in this case, I'm going to need a second point of exposure, so I make an upper eyelid approach, which lets me see how far this has been displaced backwards. I can look along the sphenozygomatic area inside the orbit to look at the poor alignment there, and then I simply elevate the zygoma again into a better position, and once those articulations look right, I scan the patient a second time. Okay? Bring in the scanner, do it again. And now you see I've got the zygoma, the arch, everything is now in good position. Okay, so now I know the zygoma is properly reduced. But now I need to see, well, now that the zygoma is in the proper position, what about the internal orbit? So looking at these scans, again, do you think this patient needs internal orbital reconstruction? Absolutely not. So obviously I'm not going to do internal orbital reconstruction on this one. So I've made that decision intraoperatively, all right? And then certainly, of course, we just put a little bit of fixation across those two articulations and close it up, and we get that kind of an outcome. And you can see the orbit. Did not need to be reconstructed. So you can make that call pre-treatment by studying your CT scans, and if you have intra-op CT scans, you can make that call intraoperatively as well. Now, again, the evidence shows by several studies now that you only need to be doing internal orbital reconstruction in around 40% of your patients, which means that 60% don't need it. And the reason I'm talking about this is the following. What I've noticed is that depending on the patient, some patients who have an approach to the internal orbit will have an unfavorable outcome from the eyelid approach. Whether you approach the orbit through the skin or through the conjunctiva, in a certain number of patients, you will have some problems. And every surgical approach we make has a potential price. So if you can avoid making an incision through or behind the eyelid, you don't have to worry about that. And the only reason, in my opinion, to make an incision there is to reconstruct the orbit. I did a study many years ago looking at approaches to the orbit, and I found that 1 in 5 patients at 6 weeks had a noticeable asymmetry or deformity of the palpebral fissure. Now, at 6 weeks, some of those are going to improve if I waited, certainly. But some of those were, there's something you should always think about, because remember, this is mainly a cosmetic procedure we're doing. Obviously, this patient's got a problem. Look at this. This is from a subciliary approach. Look at the scleral show, the lateral hooding the patient has. Look at the scleral show on this one. Here's a patient with scleral show. And if you do transconjunctival approaches, which I use all the time, the incidence of problems are less. But when you have a problem from a transconjunctival approach, it's usually a worse problem because the eyelashes tend to invert, they go against the cornea, and it's very disabling for the patient. This is one that happened to me that I had to correct. And so, again, if you don't need to make those incisions and risk the possibility of an iatrogenic problem, you're better off not making that incision. So I try to avoid lower eyelid approaches to the orbit when possible, and that's why I'm very critical about studying my CT scans to determine whether or not I need to be there inside that orbit. So why do people approach the orbital rim when they treat zygoma fractures? There are some surgeons that every zygoma fracture is going to get an upper eyelid approach, a lower eyelid approach, and an intraoral approach, every one of them. And the question is, why is that? Why would you approach the infraorbital rim on a zygoma fracture? Well, there's three potential reasons. One is to assess your reduction, to make sure the zygoma is in the proper position. One is to use as a point of fixation, to put a plate on. And the third, of course, is for orbital reconstruction. What about reduction? Okay, I think the best areas to assess the reduction of a zygoma fracture are the sphenozygomatic area here and the buttress. Okay, if you've got the arch exposed, certainly that helps, but most times you won't have it exposed. What's the value of this? You can see that from intraorally. You don't need to make an incision up here just to assess the reduction. So I don't think you need to be doing approaches to the orbit just to look at the alignment for reduction purposes. What about to use them as a point of fixation, to put a bone plate on there? Well, what value is that bone plate going to be? You're going to use the smallest plate you have, the thinnest plate, because it's so palpable here. That's the thinnest tissue in the midface. So you're not going to put a strong plate there. You're simply going to put a very small plate. So how much fixation is that really going to provide you with? Probably not much at all. So for me, and by the way, you can also put an infraorbital plate through a transoral approach just fine. So I don't think it's a great thing to use for a point of fixation either. But certainly if you need to reconstruct the orbit, that's when you need to make an incision either through or behind the eyelid. And that's 40% of zygoma cases, okay? Now, I think it makes sense to treat zygoma fractures with an algorithm. And so I'd like to, because I think that you've got to understand these are largely cosmetic operations. Some approaches have the ability to cause iatrogenic deformities. Not all orbital fractures, or not all zygoma fractures need to have the inside of the orbit reconstructed. And so we can treat these, I think, many of them with minimally invasive surgical procedures. And so I think we should always individualize our treatment. This is an algorithm that I find very useful when you don't have intraoperative CT capabilities, only pre-treatment CTs. Let me walk you through it real briefly. If you've decided that you do not need to do internal orbital reconstruction using your pre-treatment CT scans, I go ahead and just reduce the fracture by whatever technique you like, yeah? Now, if it pops into place and it's stable there, you're done. If you're not sure that it's properly reduced, or it reduces but it's unstable, my first surgical approach is going to be a transoral incision at the zygomatico-maxillary buttress. If after opening that, I can tell that I'm properly reduced, I'll put a bone plate there, which is now reduced and stable, I'm done. If after I've opened the oral cavity, I still cannot determine if the zygoma is properly reduced, my next point of exposure is going to be an upper eyelid approach. So I've got in the mouth approach and now an upper eyelid approach. And now I can align the frontozygomatic and the sphenozygomatic areas. I can align the buttress from intraorally. I'll be reduced, I'll be stable, I'm done, okay? So that's the algorithm I use when I decide using my pre-treatment images that I do not need to perform internal orbital reconstruction. And I think this makes sense to me. I've used it for many years. And I think if it makes sense to you, then you and I would be treating these pretty much the same. Now, if you have intra-op CT available, then it changes the algorithm some. You can go ahead and reduce the fracture. If it's reduced and stable, you'd simply scan them intraoperatively. If it's reduced and stable, then there's no need for internal orbital reconstruction, you're done. But if you're unsure, then you can go ahead and open whatever areas you need to be sure it's well reduced and then scan them. So there's different algorithms for whether you have only pre-treatment scans or if you also have intra-op scans available, and I think these really make sense to use. Now, if you've got a case where you have decided we need to do internal orbital reconstruction, I think there's a sequence you should think about using. And let me walk you through this. Here's a guy that's got a pretty displaced left zygoma fracture, and you can see it here. And I look at this, and I think I'm going to have to reconstruct this orbit. Okay? So I know using my pre-treatment scans, I'm going to do internal orbital reconstruction. Okay. So the first thing I think you should do is go ahead and expose the fracture with whatever exposure approaches you feel are necessary to treat this. Now, certainly, one of those approaches has to be to the orbital floor because I know I need to reconstruct the orbit, okay? So in this case, I use a transoral access. I used it looks like a transdermal approach to the orbital rim, and I did a upper eyelid approach to get to the frontozygomatic, sphenozygomatic areas. So I used 3 surgical approaches on this guy. Now, do not go in and try to free the trapped orbital tissues. You expose the rim, but do not do a deep orbital dissection yet. First, disimpact the zygoma. What do I mean by that? Take the zygoma and move it laterally. Reduce it or even over-reduce it, because what that does is it opens up the hole in the orbital floor. Okay? So by doing that, you open up this hole, and now these trapped tissues are much easier to dissect and get out of the maxillary sinus without shredding them. So then you go ahead and free the trapped tissues, get your retractor under there, and then, of course, you can reduce the fracture, the zygoma fracture, apply fixation as necessary, and then lastly, reconstruct the internal orbit. So now we've got the zygoma is reduced, it's got some hardware on it to hold it in place, but we still have this large hole in the orbital floor, so the last thing you do is reconstruct the orbit. In this case, we use metallic mesh. And these are the post-op images on that patient. So by doing that and using that sequence, you're a lot less likely to shred those delicate orbital soft tissues. Make the orbit bigger to do your orbital dissection. Then reduce the zygoma and then reconstruct the floor of the orbit after that. So it makes the most sense to do it that way. So just a couple of cases before I finish, just to show you that not all zygoma fractures require a lot of treatment. This is a guy that got kicked with a boot. His zygoma is quite displaced. You can see he's got a downward slant to his palpebral fissure. You can see how flat he is here. And that's pretty displaced. It's a pretty displaced fracture. But look at the internal orbit. In my mind, that one does not need to have internal orbital reconstruction. So I simply, in this case, used a row elevator through a Gillies approach, because he does not need internal orbital reconstruction, so I reduced the fracture. It reduced and was stable, so I was done. It took about 10 minutes. Yeah? These are the CT scans afterwards. You can see things are lined pretty nicely. And what about the orbit? Look how the orbit aligns itself. So there was absolutely no reason for me to be inside that guy's orbit, okay? Yeah. This is him sometime later. And the scan sometime later. You can't even tell he's had a fracture. Another person who has, let's see, a pretty moderately displaced zygoma fracture, but look at the inside of the orbit. I look at that orbit and think, I do not need to do orbital reconstruction on that one. So I'm not going to make an incision to the orbital floor. In this case, I was able to treat her only through an approach through the mouth at the buttress area. So She doesn't need orbital reconstruction. I reduced the fracture. I was unsure that it was properly reduced. So I did a transoral open reduction. I could reduce the fracture, it was stable. I put a bone plate on it, it's reduced and stable, and I was done. 1 point exposure, 1 point fixation. 40% of the zygomas I treat, 53% are treated in that way. Yeah. And this is the immediate post-op. You can see how nicely the orbit looks. There was absolutely no reason for me to do orbital reconstruction there, and the patient. And lastly, another guy with a very displaced zygoma. And you can see that's very displaced. What about the orbit? Yeah, pretty bad. A lot of stuff falling out. It's a large defect. This is a guy that I think will need internal orbital reconstruction. So how do I treat this guy? Well, I do not put this guy into my algorithm, because in this case, I know that I'm going to need 3 or 4 point exposure, and I'm definitely going to need an approach to the orbital floor. In this case, we exposed through a coronal approach. We did you can see the sphenoid bone here and how far back we are on the lateral wall of the orbit. This is the infraorbital rim. His is his palpebral fissure here. You can see how displaced that is. And of course, at the buttress, you have just cornflakes. And so we just simply put everything back together. In this case, we had a large orbital defect after we put the zygoma in this place we wanted it, which we then grafted with bone grafts. In this case, could have used mesh, whatever. And you can see the kind of outcome we can get with good reconstruction, good alignment, good reduction, and a good internal orbital reconstruction, and the patient sometime later. So my point here is that when you see zygoma fractures, you should always individualize treatment. I would recommend you not just automatically decide I'm going to make 3 surgical approaches to the patient, because remember, this is mostly cosmetic surgery, and every one of the approaches we make could make you pay a price. Thank you.
Thank you very much, Professor Edward Ellis, for your very practical approach and pearls of wisdom. One more outstanding talk by you.
There was a picture, there was a film, Bold and Beautiful, a TV serial. Now I invite Bold and Beautiful Dr. Vikas Dhupar.
Check. Before that, sorry for the interruption, sir. Just a second. I request our honorable chairpersons and our organizing chairperson, Dr. Dhirwani, sir, our scientific chairperson, Dr. Shari Thomas, sir, to please present a memento to Dr. Edward Ellis on the stage. I request her to please join to present a memento to Dr. Edward Ellis. Had a great time listening to Dr. Ellis. A big round of applause for him.
He has been doing an excellent work which has been exposed to the world since many years. And he has an experience of more than 28 years, and he has number of presentations, 48, and many chapters in the books. He is president-elect for the Association of Oral and Maxillofacial Surgeons of India. Another feather in his cap that he is a member of Dental Council of India, and my colleague there in DCI. Dr. Dhupar, please.
Good morning. Thank you, sir. Thank you for the introduction, and thank you for Bold and Beautiful. I think before we start, a lot of you would be happy that I am also a candidate for hair transplant, and hair transplant has come to maxillofacial surgeons with a lot of effort from the Dental Council of India, which you must be well aware. So I think I'm one of the candidates. Next time we will be with hair, sir. Thank you very much. I do not really know how simplified I can make this topic, which is already spoken in depth by Professor Ellis. And most of the pictures and most of the thoughts which has gone in making this presentation would be probably a repetition. Since I took the hard work of doing this presentation, I would like you to just bear with me and be on the same page, and would like to tell Professor that we are almost on the same page as what he is in management of our zygomatic complex fractures. I come from a smallest state of the country, Goa, and this is a beautiful campus with my team, which has been exposed to a very high volume of trauma. So basically what I wanted to do is make you understand how do we go about and make a simple plan for a repeated plan for doing zygomatic complex fractures. Numerous names, but I would like to change it after the lecture. I would say it more appropriate to call it zygomatico-maxillary orbital fracture than ZMC's fractures. Zygomatic maxillary complex fractures are second most common fractures of facial injuries, more for male predictions. Peak incidence on second and third decade of life. Left side more commonly involved than the right side. It's roughly a quadrilateral bone with 4 processes, and important to note that it is part of the major buttresses which are in the midface. So reconstruction is an important part of it, because this is where the soft tissue will drape around and it is going to reflect as a cosmetic deformity. Whenever a zygomatic complex fracture is there is involvement of 4 buttresses, that is the frontozygomatic, infraorbital rim, zygomatico-maxillary, and zygomatic arch. Always remember there is an orbital component with involvement of the lateral wall and orbital floor. H.D. Gillies had made a mention that mala bone represents a strong bone on a fragile support, and it is for this reason that the body of the bone is rarely broken. The 4 processes, frontal, orbital, maxillary, and zygomatic, are frequent sites of the fracture. Patterns have already been described. The fracture patterns will also depend on the magnitude and force of injury. In an anterior direction, there would be a clockwise rotation, whereas on a lateral forces will result in a counterclockwise rotation. There are 3 key to these fractures. Fractures lines would extend from the inferior orbital fissure. This is what usually you see, but this is not what you will come across these days with high volume impact. You are seeing multiple more lines we are up with the study which will be soon publishing, with multiple more lines which we will see, which complicate the matter. And when we talk about mechanism, a direct blow results in a relative inbending at the point of impact and relative outbending in weaker points. Violent blows to the contralateral midface causes fracture dislocation of zygoma by reciprocal transfer of forces from opposite side of facial skeleton. Remember, dislocation can be in posterior, inferior, medial or lateral direction. And if you draw an imaginary line thinking the fractures would be stable or unstable along a vertical axis and horizontal plane, the fractures would be stable, and along a longitudinal axis, the coronal plane would be unstable. Common clinical findings, what we come across are facial asymmetry, periorbital ecchymosis or crepitus, infraorbital nerve numbness, lateral canthal dystopia, trismus, restricted range of motion of the globe, occlusal disorder. Also remember out here, it is mandatory to have a formal ophthalmic evaluation of a patient by an ophthalmologist whenever you are treating a zygomatic complex fractures. Diagnoses earlier were made basically on plain films, which I do not think is a standard. The gold standard for today is a CT scan, which has to be in an axial, coronal, and a sagittal plane. The axial planes will give you a dislocation, whereas coronal and will give you an internal orbit and again a dislocation. Sagittal is very helpful understanding the flow. Now it is important at this point to evaluate the X-rays as mentioned to understand what we are going to do for the patients. It is important to see for comminution and for displacement. And here we could judge, like most of us do not, most I do not think any of the centers would probably be having an intra-op CTs. It is important to assess pre-operatively how are you going to manage these patients. MRI again has a very, very limited role unless there is an ocular involvement in a major. Here is a case, a young lady who was going for an exam, was very stressed out, fell down from a bike, came with a swelling on the left side, which on a CT scans showed a mildly displaced fracture. This is a pitfall, means this is a case we thought we probably would reduce, fix, opened intraorally, fixed it. Thought we did a good job. We came out, there were bizygomatic width, was excessive bizygomatic width. There was an swelling on the left side which was clearly seen. Patient was very, very unhappy about the whole thing. Look at this. What we have done, we have even after when we took up the patient, we have created further problems for the patient, and the results were not at all satisfactory. And the post-operative, we did an analysis and we came that in fact the volume was better compared to the normal side than what after the surgery. So the pitfalls what we came across, and based on this we usually have developed a pattern on how we manage these patients. The pitfalls was poor planning, inadequate exposure, inadequate fixation, not understanding the exact pattern how the fracture would be there and how to manage it. So in the present times, the CT is going to guide your management. You will have to look for the degree of fracture displacement, whether it is a single or versus multiple fragments, combination of the buttresses, status of the orbital flow, status of the NOE complex fracture. And whenever we are going to manage this, and before we enter our orbit, we need to have a stable rim around on which, or stable framework on which we are going to build the flow. So generally the main controversies which we come across is, should a surgical exposure of zygoma should be in 2 or 3 locations routinely be performed to determine whether reduction has been adequate? Should the fixation devices be routinely applied? Does internal orbit require reconstruction? Now generally, as mentioned, a lot of patients could be just managed with a close reduction. And the basic indications out here would be a displaced fracture which is amenable to minimal invasive reduction techniques. Disadvantage would be less invasive technique. However, disadvantage would be difficult to assess on table how has been your reduction. There would be a risk of displacement due to absence of fixation of hardware. Reductions could be done with the help of bone hooks, screws, or threaded reduction tools. Also, what we could do is approach and do a temporal approach or an intraoral approach with the Gillies elevator or Bristow's elevator or a Rose zygomatic elevator. Intraorally Keen's technique could be followed, and these cases, most cases, could be significantly managed in this particular way. When we come to open, there are a couple of factors which we need to think about. One is the timing, the number of buttresses to be exposed, what is the type of exposure we are looking at, what is the type of fixation we are looking at, whether orbital floor exploration is required or not. When we talk about timing, early surgery performed before the significant swelling is what we look forward to. Late would be after the resolution of significant edema. But generally possible, we should work out these cases within 7 to 14 days. A stable non-displaced fracture which you have reduced needs to be observed weekly so that if there is any intervention required which you need to take. Also remember, after 10 days, masseter begins to shorten. Looking at exposure, it could be, the approaches could be a superior lateral, lower lid, transconjunctival, coronal, or vestibular. Superior lateral can be, orbit margins could be approached through a lateral eyebrow or upper eyelid. Lateral eyebrow gives a little limited SS, whereas an upper eyelid or blepharoplasty incision would also help to expose the sphenozygomatic suture line. Transconjunctival approaches could be subciliary, subtarsals, infraorbital. Now, rarely infraorbitals are used because they lead us to a lot of scarring. The subciliary is a preferred approach, and which could also be extended laterally. Transconjunctival in isolation, or depending, combined with a transcranicular or transconjunctival with skinning extensions, could be an important part of your, should be an important approach. Rarely, if the zygoma roots are required, just a preauricle auricular or a coronal approach, which gives us a very extensive exposure, and this generally, if there is any frontal involvement, nasoethmoid involvement would be an preferred approach would be. And depending upon, the incisions could be well placed so that post-operative scarring could be, less visible. Intraoral is an important, or vestibular is a very important part. Usually this would always be there whenever we do an ZMC's fractures. Whatever incision or approach you choose, remember, when you are going to expose, and there are multiple fragments, multiple areas, we need to get them into alignment, and there may be a time where we need to expose the sphenozygomatic suture line. Well, that is what is important to us. Thinking of fixation, lot of debate, 1 point, 2 point, 3 point, or 4 points. Now, why this comes up is generally when we think on the zygomatic articulations, the point of assessing the accuracy are very different from the stability of the areas which can be fixed. So if you have to assessing the accuracy, the sphenozygomatic suture line is the most, the area which gives you the most accuracy, whereas FZ gives you the poorest accuracy. Wherein you do a fixation, zygomatico-maxillary buttress is the most ideal line, and infraorbital rim has the least value. In a 1-point fixation, indications are displaced, simple non-commutated fractures with minimal separations. Stable reductions is not achievable using a close reduction. Less invasive techniques, advantage, and it snaps back into reduction. Disadvantage, difficult to assessment of proper reduction of non-visualized sites. The point which is done is the zygomatic buttress area, where a single plate can be fixed. 2 points, displaced fractures requiring 2-point exposure to verify reduction. Anatomic reductions cannot be confirmed using 1-point fixation. Advantage, allows visualization of sphenozygomatic and FZ suture line in addition to the ZM. Difficult to assessment of proper reduction at non-visualized sites. 2 points can be the FZ and the buttress area. When we talk of 3 points, it is usually done in displaced or comminuted fractures requiring 3-point exposure to verify reduction. Allows for a visualization of infraorbital rim in addition to SZ and FZ along with ZM areas. Disadvantages, difficult assessment of proper reduction at non-visualized sites. The sites are FZ, infraorbital and zygomatic buttress area. But again, infraorbital is an contentious area which we look into. A 4-point is generally when an arch requires to be reduced. Indication would be a complex zygomatic fractures where exposure of the zygomatic arch is necessary to ensure proper reduction. Advantage, allows for visualization of the arch, which is a key indicator for your proper reduction. And however, disadvantage would be a visible scar, time consuming, risk of temporal hollowing, risk of injury to the temporal branch of the facial nerve. So this is what would be the points. So in addition to the other points, you would add to the zygomatic arch. There's a lot of debate whether it is 2-point or versus 3-point. A study which says 2-point fixation by Fazer said that it would be an ideal to do it, and most of the fractures would be stable post. However, a larger study by Nishita Gadkari and all concluded that 2-3 points do give a better stabilization of it, but it is again a point of contention. The sequence, important is how would you go forward if you're thinking of fixing the multiple points. Now the ideal would be to place 2 holes on the FZ area, followed by the arch, followed by the infraorbital area, buttress area, and lastly you go in for reduction of the internal orbit. And this would be the surgical pictures of the same procedure which is done. The last point of debate would be whether orbit exploration is required, yes or no. Generally, when would we need an orbital repair? Where there is a persistent diplopia, positive foreduction tests, evidence of extraoral muscle entrapment, large anophthalmos, large orbital floor defects, abnormally low vertical globe levels, combined floor and medial wall defects, blow-in fractures with exophthalmos. Now, when you do an orbital repair, you could do it with the 3-point fixation where the arch is not done. And this is a patient where 3-point fixation has been done with the floor repair. Here we can see a patient whose globe, there was a level had dropped down, there was a malar deformity. There is a gross displacement, and here was a patient where the floor exploration was done. This is the post-op pictures of the same patient where the levels are pretty good, and the post-op CT scan, even the medial wall was repaired, and a perfect S on the floor of the orbit was placed. This is what is a case of a 3-point fixation. This is the post-op analysis of the same patient where orbital volumes were compared with the right side to the left side, which was fractured, and post-op is what we are getting is there is a slight discrepancy, but almost there. When we talk about a 4-point fixation, that would include a zygomatic arch fixation, and it would involve a coronal approach to it. Say a patient with a left zygomatic complex fracture. Surprising on this, there was no restriction of the gaze, but the ocular levels were not the same on either side. There was a gross displacement, and that was the reason it was decided on this case with the frontal bone fracture to do a repair. A coronal approach, the frontal bone was repaired, all the points were fixed with the and through a transconjunctival approach, preformed plate was fixed on the orbital plate was fixed on the floor. These are the post-op results of the same patient. Good ocular level, good facial symmetry, no disturbances in the ocular movement, quite a good balance. And these are the radiographs which are showing the reduction and fixation of the same patient. In 3D formatted, look at the arch forms here. Then again, post-op, we did an orbital wall volume analysis which through our figures which we had a pretty symmetrical orbital volumes on the either side. Coming back to the same patient, which we thought was not very well done. So her radiographs were again taken where we realized that the zygomatic arch area, the bone has lifted up. Took a coronal approach on this, exposed the FZ areas, the arch area. However, infraorbital area was not exposed, was not fixed in this case. Fixations were done, quite a good symmetry on the post-op.
Thank you, Dr. Dupal. He has rightly analyzed the data from a government hospital where you get patients in plenty and most of the patients are not very affording type. And his simplicity of approach is really impressive, very impressive, and I think he needs all the appreciation. Thank you. Now I invite Dr. Andrew Edwards. He will be speaking on current aspects, current concepts in orbital trauma.
This afternoon. It's always a delight to be back into India, fueled by masala dosa and kingfisher, my two most favourite things about India, as well as the people, of course, as well. That's me. Following on from that, I have my disclaimer. What are we going to talk about? Well, I'm going to talk about actually going into the orbit. So apologies, Dr. Ellis, we are going into the orbit in my talk, I'm afraid. So we're talking a little bit about current concepts in orbital trauma. Just a few of my thoughts, a few of my muses, a few of my readings of the literature, because we do evidence-based surgery. So it's just to give you some of my thoughts about orbital trauma. What I'm going to talk about, I've split it into two bits. We're talking about primary orbital repair, this is the immediate repair, and then we're talking about the one that you often see where it hasn't been treated or it's been treated inadequately, the post-traumatic deformity or the secondary orbital repair. As with any fracture, we've heard that before this morning as well, we need a thorough comprehensive assessment of the fracture pattern. Important that we do that. We need to get a pure clinical, a medical, anatomical, and most importantly functional considerations. That's very important with facial fractures, and obviously that's supported with objective evidence, and that's from detailed imaging. And when we're dealing with any orbital trauma, we want to have a full orthoptic or ophthalmological examination. That's paramount before you go anywhere near an orbit, that you need a full orthoptic examination, not shining a light in somebody's eye, not moving your fingers around, a full orthoptic examination. We talked about the radiology assessment, CT scans, empirical now that we do them, particularly in the orbit, at least a millimetre slice, and then using that we can use now for our planning software. MRI is actually quite helpful, and I'll show you an MRI. Some of the software we use, this is just one of my planning software we use, but MRI is actually quite helpful. This is actually a pediatric blowout fracture. I did not request the MRI scan. The MRI scan was actually requested by my pediatric colleagues who'd had this poor chap, this young boy in the ward for 48 hours who was vomiting all over the place and forgot to check his eye. And you can see there quite a significant amount of herniation of the soft tissues, and you don't get that appreciation of the soft tissues when you actually go in exploring it. So the MRI scan's quite good. I'm not saying you MRI scan every orbital floor fracture, of course. A little bit of an algorithm here about what to do. You have obviously the emergency management. We've got surgical and medical treatment. The emergency management of a proptotic retrobulbar hemorrhage is medical management, surgical management. Medical management only buys you time. You've got to go in there as a surgeon and decompress the orbit. And then obviously your imaging, diagnose your fracture pattern. We're talking about an isolated orbital floor fracture here. We're not talking about the ZMO fracture. And then obviously formulate a treatment plan based on your diagnosis. How do we get into the orbit? Now I'm talking about going into the orbit here, so apologies to everybody say we try and avoid going into the orbit. Here we have to go. This is a great series of incisions that's in the textbook of ophthalmic plastic surgery. As you can see there are multiple ways of getting into the orbit, whether you want to get into it for trauma or whether you want to get access for tumour surgery, whether you want to get into the superficial orbit or indeed the deep orbit basically. So there's multiple incisions that you can make. What's my modus operandi? Well, I sort of break it down into two bits. You've got the anterior lamella, which is essentially the skin and muscle, the orbicularis. And you've got your posterior lamella, which is a conjunctiva and tarsal plate. So for the anterior lamella, you've got three incisions, subciliary, subtarsal, and what we would call an infraorbital incision. And the posterior lamella, which is the conjunctiva and the tarsal plate, you've certainly got these three, what I would call transconjunctival incisions. Basically, you can either go a retroseptal or a preseptal route, and I'll tell you a little bit about that later on. You can extend these both medially and laterally, which gives you superb access to the orbit. So you can do a transcaruncular or medial transconjunctival, or laterally with what they call, Moss called the swinging eyelid incision, or the extension of the lateral approach, basically. So where do you get? Well, you get fantastically access, and extending it both medially and laterally, you can see where you can get into all aspects of the orbit, all the way right up to that greater wing of the sphenoid and up onto the medial wall, quite impressively as well, from a transconjunctival with both a medial and lateral extension. My tips, I use a corneal shield, or indeed the transconjunctival approach, you use the conjunctiva to protect the globe. Retraction sutures are paramount. Use your assistant and use retraction sutures. As surgeons, tension is our friend. Make things tense, it's much easier to incise. I use bipolar cautery or monopolar cautery all the time when I'm working in the orbit. It's got to be sharp dissection. Obviously incised in the periosteum, if it is periosteum there, sometimes in trauma the periosteum is shredded, and use sharp elevation and then retraction sutures as well, basically. So, transconjunctival approach. Dr. Ellis has alluded to it, that we are maxillofacial, we are cosmetic surgeons. Please do not make incisions on the skin, yeah? Don't use the skin. Please, please don't do that. So what do I prefer? Well, I prefer to go transconjunctival preseptal incision. That's in front of the orbital septum, but sometimes the orbital septum's trashed and you have all this fat coming through. But if it is there, I prefer this particular approach. I acknowledge Simon Holmes here, a colleague of mine in the UK. Use a Desmar retractor and tent the lower eyelid over it, and you'll see it will blanch. You can see there on the green arrows the blanching. You see the tarsal plate on the red arrows. And you can see this avascular area, yeah? And that avascular area is a fantastic area to start your dissection, yeah? So you start your dissection down there on the prevascular plane, basically. And then you get into that prevascular plane, and then you can then work your way down, and you can visualize the orbital septum. There you are, there's the orbital septum there, indicated by the blue arrows. The green arrows are tenting the conjunctiva up, basically, yeah? And they're tenting it up over to cover and protect the globe, basically, yeah? Be careful though, because you can see that Desmar retractor shining through, yeah? There's a very, very, very easy way you can buttonhole this, and trust me, I've buttonholed it on a couple of times, so just be very, very careful. How about your cantholiasis? A lot of people get twitched about doing a canthotomy or cantholiasis. Tension's your friend. Again, a Desmar retractor in there. You can see the tension put on by the blue arrows. Sharp incision. Crush the area to make it avascular. There's your tendon, yeah? Sitting there, pops up at you and says, oh, hello, what am I going to do with it? Take a pair of scissors and caudally, that's point them down the way, just cut through it, yeah? In one fell swoop, cut through it, and there you go, you've exposed it, and that's the lid swing. And you get superb access now following a subperiosteal dissection, yeah. What's the evidence? Well, this was got a good study by Zhang, just came out this year actually, and he looked at 14 trials looking at the transconj approach and subciliary approach, basically, or a skin or the anterior lamellar approach. There are complications, and Dr. Ellis talked about that, but the TCA has a significant lower incidence of ectropying and scleroshow and a visible scar. But however, as Dr. Ellis pointed out, you get this inward reflection of the lashes and an entropion, and that's often worse than an ectropion because lashes irritate the conjunctiva. So when do we time surgery? Well, lots of trials out there. Again, this is Zhang's work from 2022, the most recent stuff I can find, and they said within 14 days it reduces the incidence of diplopia in ophthalmos. Jezazira, again, a very, very pertinent paper. This was about early repair way back in 2020, a few years ago now. And he was essentially saying cut-off time is 14, or he extended it to 28 days. And we know fine from this paper here that if we delay the surgical intervention, we get more complications. We get tissue fibrosis, you get atrophy. Scarring is not the surgeon's friend. We don't like scars. So, what do I think? And again, this is Simon's work. Again, this is a great paper for all you trainees if you want to have a little look at it. Certainly pediatric trapdoors, we want to operate on them as soon as possible. And there's nothing worse than a vomiting kid all over the place. It's not nice, so get in there quickly and repair that. 4 to 10 days, it allows all the swelling and all this to trouble down, and it allows us to fabricate a custom-made plate if indicated, and we'll talk about this slightly later. After about 4 weeks, about a month, all these fibrous adhesions start happening. And then basically after 6 weeks, your orbit, it's a revision case. Forget about going in there. As in my books, it's 6 weeks, it's a revision case. It's a secondary deformity, basically. What about materials for reconstructions? Well, there's a classification for, and this is Jackery's paper, a seminal paper way back in 2007, which talked about the 4 classes of fractures. Floor being less than 2 centimetres, class 3 greater than 2 centimetres with involvement plus or minus medial wall, and then a class 4, which is the whole of the orbital floor and the medial wall. That's what I have found has been stuffed into the orbit over the years. Yeah, it's massive amount of stuff, and people are still stuffing this stuff in. That's what we tend to use these days, titanium or cobalt alloys, or indeed we tend to use possibly some of the non-resorbables in the way of PEEK, porous polyethylene, or in PDS, polydioxone, some of the resorbable stuff. So it's very restricted what I use in my clinical practice. Titanium, it's our friend. We've been using it for years. We stick titanium implants in down, so we can either have preformed titanium plates now, or we can go to what we call the PSI, the patient-specific implant. And I think surgery is now going the line of patient-centered or patient-tailored implants, basically. So you can see here, sorry, that's not come out all that well. We can use a stereolithographic model now, so we can mirror the opposite side. We can reconstruct it now on the mirrored good side, onto the bad side. We can then use the stereolithographic model to produce another model and pre-bend a plate on a stereolithographic model, basically. What about patient-specific implants? Well, there's a lot of studies said that you get a better outcome with PSI compared with the generic ones that you can buy off the counter, basically. They are more precise, they give you great outcomes, and their revision rates are lower, and again that came out in a few works and a few papers as well. The reconstruction of the defects with these gives it a particularly good for single wall fractures, but as soon as you start going on to multiple wall fractures, then it becomes more complex, basically. So my take-home message, basically, if you've got a pretty much large fracture, I think you should maybe think about a PSI, because some of these custom-made plates will not get you to where you want, basically. So there's a lot of evidence coming out now saying that, yes, we should go in for PSI. So these are 2 papers, literally a month apart this year, one in April and one in May. And this paper, the first paper by Timashek, said that the growing amount of literature suggests PSI can allow more precise reconstruction of orbital volumes as well as decreased post-op complications. Koteka and my colleagues from the UK, again, a systematic review said, well, there wasn't actually any statistical evidence to support that. And the results of the study said it should be left to the discretion of the surgeon, basically. So, make your own mind up what you want about that. So, again, this is about evidence. When we look for the evidence, we can find a lot of stuff that contradicts what we want. I still use PSIs in complex cases. So the last bit now, maybe the last 5-6 minutes, I'm going to talk about this horrible late post-traumatic enophthalmos, a secondary deformity. This is what you want to try and avoid. This is a disaster, basically. What is it? Well, basically, it's basically the globe goes back in there, and basically what happens, it's an increase in the orbital volume, isn't it? Bony orbit. The bony orbit's increased, basically, and you get a displacement between the globes, and it's known as hyperglosis. So essentially what you've got is you've got this constant orbital tissue, but it's in an enlarged bony orbit, yeah? And things have got to go somewhere. If you increase something, it's got to go somewhere, and tends to what to do is it drops down. So how much is it? It's significant. Well, 2 millimeters, it's what the human eye can pick up. Anybody who's got enophthalmos less than 2 millimeters, you cannot see it. 3 and 4, most people will pick it up. 5 is horrible. It is horrible. You don't want somebody with 5 millimeter enophthalmos, and this was Kuh's study way back in 2006. What are our treatment goals with any fracture or any surgical treatment goals? Aesthetic surgical access, don't touch the skin, please. Yeah. And then we need to correct that 3D facial skeleton. We need to have that repositioning of that globe, if they have a globe that is, because they may not have a globe, into this reconstructed internal orbit. And obviously we want to limit our dissection and correct any soft tissue defect, and that's the most important thing basically. So what do they look like? Well, you get this supratarsal hooding, you get this sort of dropping of the eye, and you get this reduction in the globe basically, and it just looks pretty horrible, doesn't it? Treatment protocols, well, there's lots of them out there. You know, conventionally we were using X-rays, CTs, we were doing V-planning, we were doing PSI, navigation, and then as Dr. Ellis talked about, intraoperative imaging. I don't have the beauty or the luxury of intraoperative imaging. Approach, please learn how to do this approach, yeah? It's very, very nice, very good, very safe. And it gives you cosmetic results basically, yeah. That's, as I say, where you want to get to. Sometimes with these complex cases, you may have to get to the upper orbit, yeah. You may have to get there. You have to have a coronal approach. That's the only way. Don't go on any other decision. Coronal approach. Again, fantastic access and also aesthetic-wise. Mobilize these orbital contents. Remember your safe areas. Identify the attacked bony margins, but again, the fat's often in there with all that sinus mucosa. And what you want to identify is this posterior medial bulge, and that's the way it gives you the projection of the globe, and it gives you the support for that basically. My area of dissection, I start from 1, which is inferior orbital rim. I go laterally up to the sphenozygomatic area. That's the lateral wall. That's your safe area. Everybody's safe there. It's safe, you're happy. Then you head back down the way, basically, into the inferior orbital fissure. There's usually a lot of stuff in there. Bipolar it. Use a monopolar or bipolar. And then you can see your posterior ledge where you're going to place your implant on. And then you get to your bony ledge, and then your medial dissection is up to number 6 basically. So if you just remember that little algorithm basically about how you get in there. And you can see there again, you get superb access away up onto, this is now looking medially, the green arrows are away up the medially. Now we've done a transcaruncular approach basically, and you get superb access. We can put all sorts of nonsense in there. We can do on stereolithographic models, this pre-bent one. Now we're having PSI ones printed basically. Navigation, I don't use navigation. I've worked with Alex Schramm. I went out to his unit to learn about it. It's excellent. You get superb results with it. It's very, very time consuming. It's costly. You need the equipment. And it's fantastic, particularly in the post-trauma cases as well, and in complex reconstruction. So if you're available to use it, use it. PSI is definitely the way forward. They're superior to the shaped implants. They're much better. They're patient-directed. They're patient-specific, basically. And we've been using them now way back since 1997, basically. As I said, the complex cases now, we're now going on to patient-centered, patient-specific, patient-directed implants, basically. And these are 3D printed orbital plates. Basically, they're custom printed for you. And on top of that, you can have virtual surgical planning, and you get your guides now as well. This one I'm showing is the one that we alluded to earlier on the zygomatical orbital fractures. You can see here by the patient-specific guides and the patient-specific implants. So these are available now. They are costly though, that's the only thing. They are a particular cost to you guys. So, but they are fantastic, and they are incredibly accurate and give you superb results when you're doing that. Last couple of minutes, correction of the soft tissue defect, very difficult because, you know, how do you predict all this fibrosis and atrophy? Do we need to treat it? Well, you know, we've reconstructed the bony orbit. Do we need to construct the soft tissues? Well, you know, I've looked at this, I've spoken to it. They've been stuffing all sorts of things into the orbits to try and correct the soft tissue volume, because you get loss of fat, for example. You've been putting silicone oil, but they come out. They're putting all sorts of horrible implants in, they come out. Fat disappears. Coleman fat graft disappears. Somebody's even reported on putting all sorts of polyacrylamide gels in, but they all fall out, they all migrate out basically. So they haven't found something that will actually correct the soft tissue. Enophthalmic wedges are fine. I have used them. They will allow you to project the globe forward. But if you've got a custom patient-specific implant, this will do it for you. Yeah. So you don't need to use this. If your patient-specific implant is identified, that will actually help bring the the globe forward. And as Dr. Ellis pointed out, and putting your finger in there, you're actually halfway down to the. So again, remember where the equator of the globe is. Yeah, put your finger in, stick your finger as far back as you go. You're almost halfway to where the equator of the globe is, and you can see that on the vertical arrow there, basically. If you've no globe present, well, you have to correct that. There's ball implants that they use, and I work with my oculoplastic surgical colleagues to do that. So in summary, primary repair, 4 to 14 days, except the pediatric white. Use the pre-bent titanium plate for non-complex fractures. You use PDS for simple fractures. Consider a PSI for complex orbital wall fracture. Please, please, please use the transconjunctival approach. In post-traumatic cases, the PSI, yep, gold standard, works superbly well. There are multiple methods for designing VSP. It's the one that works for you guys. Again, transconjunctival approach. If you need to get to the deep orbit, bicoronal flap. Navigation, I reserve judgment on that. If you've got it, fantastic, but don't invest in it. Thank you very much indeed for your kind attention.
Thank you, Mr. Andrews. Gentlemen, there is a very interesting question-answer session about to begin. Do not rush for lunch, because lunch is on till 3 o'clock. You can go anytime and any number of times, as Rajesh tells me. May I invite Professor Gopal Krishnan and Professor Dhupar to come on the stage for a question-answer session, please. For those who want to ask questions, there are audience mics. Please use them freely. Come.
Scientific sessions. This session is designed for you to openly ask questions to the masters in the field of traumatology, facial traumatology. So I want you to use this opportunity to use this time and ask questions. And some of you may think that your questions are not serious enough, but believe me, in surgery every question really matters. So I request the audience to come forward and ask questions, and I'm sure they'll be happy to answer. Aren't you?
Not really.
No choice. Okay.
Thanks a lot for that, Dr. Dhupar and Dr. Gopal Krishnan. When you're handling ipsilateral zygomatic complex fractures, which need coronal approach, the most common problem that I face in my practice is hollowing, temporal hollowing. How do you surmount that? Do you have any ideas for that?
Anand, what is the problem you face?
Temporal hollowing, sir.
Temporal hollowing.
Because it's a cosmetic process, and then I land up with a bigger defect, then I find it difficult.
I think the best thing would be to resuture whatever you have reflected and reanimation would be the best.
Sometimes the...
Is this using the, if you're using a bicoronal flap, for example, with temporal?
That's right, Dr. Edwards. And if it's a bilateral problem, I'm not bothered much because it's equally spread on both the sides. But if it's a unilateral problem, then the hollowing shows more.
Anand, to answer your question, I think very rarely you do a hemicoronal. Because the
Sir, not a hemicoronal, sir.
Yeah.
A coronal approach,
Yeah.
but on one side you're identifying the arch. So you're actually transgressing boundaries of the fat plane.
Yeah.
On the other side, the fat plane is intact. So the side where we are transgressing, you get more hollowing.
I honestly don't have an answer for you. Do you have? Andy?
The resuspension, when you're doing your bicoronal, if you're doing for any access of that, it's really important to resuspend all your soft tissues, basically, yeah? And you've got to use that, particularly the temporalis region, yeah? Because you will get atrophy, because there's two fat pads there, as you know, basically, a superficial and a deep fat pad. As soon as you touch fat, it disappears, you know, you do get a degree of resorption and stuff like that of fat, so you've got to make sure that all your soft tissues there. Very careful dissection as well, sharp dissection as I told it to as well. Bipolar is very good for dissecting, and that allows you to get down on the planes as well. So tissue handling and all that as well, because anything that stimulates the inflammatory response will then lead to tissue fibrosis, scarring, and indeed fat atrophy as well. And as you know, there's a couple of fat pads up there as well, which will disappear.
On a lighter note, Anand, temporal hollowing is a problem for you and me, not for our people with a lot of hair.
Very true, sir. But the supra arch region sometimes really becomes grotesque. So I was just wondering about that. Thank you.
Great. Yeah, please ask questions.
Hello, sir. It was really nice presentation. My question is to Dr. Andrew, sir. Sir, how safe it is to go beyond inferior orbital fissure? Like, what's the safe margin we can go and dissect the floor?
Again, the problem, particularly in trauma cases, we all see the textbooks and we all know where the safe areas are. We all know that, you know, where the anterior ethmoid artery is, we know where the posterior ethmoid artery is, but in trauma cases they're not there. They're often gone. It's variable as well. People's intraorbital fissures are not the same. They are different, basically. Yeah? You know, they say 35 millimeters, that's when you get squeaky bum time when you're in the orbit. Beyond that, you've just got to be sensible. You use your clinical acumen and clinical judgment, basically. You'd be surprised. The inferior orbital fissure is fine. Superior orbital fissure, yes, you've got to be careful when you're working in there, particularly if you go down on the lateral aspect. Be very, very mindful of it. But that's the problem when you get in somebody, and again in a post-traumatic case as well, the anatomy is altered. So trying to use some bony landmarks and use them as a guide. Use your millimeters as a guide, basically, but use your clinical acumen more than anything.
And sir, one more question. What is the size of the implant you use, like as a bolster, to give the projection of the globe?
Again, proper dissection, yeah, to get that projection of the globe. People mistake the fact that they think the globe is actually far back in the orbit. It isn't that far back in the orbit, so you don't actually have to dissect too much. When you're placing your implant, particularly in the primary orbital plane, you've got the perpendicular plate of the palatine bone. That's what's right at the back. As you know, you've got your 7 bones of the orbit. That's what I call the 7th bone, the perpendicular plate of the palatine bone, which sits at the back, and that's that ledge that you want to ensure your implant is on, basically. So you find that your implant has got this sort of lazy S curve on it, as we all know, whether it be a PSI or indeed a custom one. And what you've got to do is ensure you're on that. And your dissection, you can get down to that. You know, you can dissect down and feel where that bony ledge is. So you can then just drop your implant. Occasionally, in the severely traumatized orbit, you don't have that, and that's happened to me on a few occasions. Then you've got to judge where it is, and then you're cantilevering that plate anteriorly, and that's what you're doing, is you're cantilevering it off something that's firm bone. And again, you've got to have a firm orbital rim to do that, so then you've got to reconstruct the orbital rim as well. So it's having something firm to rest it on, so you're cantilevering it back the way if there is no ledge there. But majority of the time it's there, and you can find it, and that's where you want to be, and that will allow that projection of the globe to basically happen. The post-traumatic cases, it's a lot more difficult, basically, because again, everything's changed. The soft tissue component is changed, and even though you've corrected the bony orbit, and you see the patient, it's happened to me post-operatively, I've looked at the post-op CT scans with the implant in, and it looks wonderful, but the soft tissue component they've had soft tissue atrophy, they've had Hoff's tissue scarring, fat atrophy as well, and it's correcting that soft tissue. And I work with an oculoplastic surgeon when we do a lot of these cases, and he tears his hair out for what little hair he has left, trying to actually reevaluate that. And we've tried everything. We tried putting some of these fillers in and stuff. It just doesn't work. They move around and they migrate out, and they cause a lot of problems. Okay?
So can we club it with the mesh, like we put a mesh to correct the defect and then put the implant, or is the implant enough to correct the small defect at the floor?
Sorry, I didn't...
I mean to ask, if we have a bony defect at the orbital floor, plus the volume is lost of the orbit, so first we put the mesh and correct the floor, and then the silicone implant?
Yeah, start off, yeah, absolutely, yeah.
And if we have the defect smaller, like of a smaller dimension, so can we directly go, that will also add like a closer, like it will be in between and provided some support. So can we avoid the mesh in that case?
Yeah, absolutely, yeah.
Thank you.
Thank you.
Yeah, welcome.
Are you worried about the infraorbital nerve? Yeah? All right, yeah, I wouldn't get worried about it, yeah? You should be able to put your implant over the nerve. You shouldn't be putting it under the nerve. Yeah, your dissection should be over that. That nerve should be down there. You know, the nerve should be either in the canal or below it. You know, it should be well away from it. So any implant you're placing should be above that. So any tissue that's there, you should be taking that and stripping that off the nerve, basically. So your dissection should be above the nerve, basically. Yeah. So you should be taking all your soft tissue and everything that. So your implant is on top of it. Yeah, thank you.
Good afternoon, sirs. My name is Sonal. I'm from Ahmedabad, Gujarat. I wanted to ask about a very young child that we had, a 2-3-year-old child. So what would be the ideal reconstruction material for the orbital floor in a child if we cannot afford a resorbable plate? A 2-year-old child.
3-year-old child, yeah.
Yes,
I mean, trust me, I've gone in for pediatric trapdoor fractures, and about 50% of them I don't put anything in.
No, not a trapdoor, sir. A proper floor defect which requires
titanium. Use titanium.
A 2-year-old child, sir.
Yeah, and a child. Yeah.
Okay, and would we need to go in and remove it after 6 months?
No, trust
me.
me.
So the growth, would the growth be hampered?
I've done a couple of, not 3-year-old, I've done a 5-year-old with a complex floor fracture. And PDS is okay for a small fracture, but it's not, it doesn't give you that stability, yeah? And I've just went in there and cut off an adult, one of the things, and cut them down and put that in, and it's been absolutely fine.
Right, but the 5-year-old has pretty much all the growth over, no, sir? About 80-85% the growth would be over.
I've never had a problem with it, yeah. Never had a problem.
So would you have any experience with the conchal cartilage graft, sir?
I've never put a costochondral cartilage graft in.
No, a conchal cartilage.
Conchal cartilage, yes, yeah. No, as a trainee, I put about, probably 1 or 2 in as a trainee many years ago when I worked with an old-style surgeon. But yeah, I've seen it used. But no, I stick to the alloplasts now. I'm a great fan of alloplastic material, which I've been used for years, and in my hands it seems to work well, and I've not had problems. So I've said before when I talk, I keep things simple. I don't try to overcomplicate or overgild the lily, because if you start looking for things, this looks nice. I mean, when I put that slide up of all the different things that you can put into the orbit, you know, they're all probably case series or case reports, and they never tell you the complications. You know, a year or 2 down the line, they usually come floating out on a sea of pus or something like that, or they cause, you know, a soft tissue reaction or something. So I tend to keep it simple. Use what I've been using for years, and use what I know is biocompatible. Know what gives me the right outcome, and that's why I do is I try to keep it simple, basically. So keep it simple is fine. That's what it's my take-home message, Sonal.
Thank you, sir.
So just to add to that, you know,
yes,
your choice of reconstruction material depends on the size of the defect.
Yes, sir.
Okay? So you can't use a conchal graft for large defect.
Right, sir. So my question was, what happens to the growth then? Is the growth affected in a 2-year-old child? No. We don't need to go back in and remove
If I'm not wrong, I think the orbit growth is already complete.
Yeah, by that time, yeah, 5-year-old, you know, and I've never had a problem. Yeah.
Right. Thank you so much.
You're welcome.
I have a question, sir. I'm Dr. Vikiva. So I have some of these cases with orbital floor fractures, and they presented with here. So, do I go in and intervene immediately and try to relieve the compression, or not decompress them, or should I just wait and watch? Because some of them actually subside in the next week or 10 days, just medical management.
So this is on an isolated orbital floor fracture you're talking about? Yes. Primary one, yeah?
Yes.
Okay. So again, talked about as well, evaluation, CT scan, yeah? If it's an isolated orbital floor, look at your CT scan. Is there any entrapment? Yeah? Have you got soft tissue incarceration in there? What's the size of the defect as well? You know, you've seen the classification there. Is it a class 1 or is it a class 2? Again, less than 2 centimeters squared, they say that you don't need to worry about that because the risk of being ophthalmics is low. Formal ophthalmological evaluation immediately, yeah, by my ophthalmological colleagues, and then review again. tend to leave orbital floor fractures within and fix them in that sort of 6 to 10 day window basically. Gives me a time to reassess things to see if the diplopia is caused by incarceration or whether it's neurogenic and it will settle, and then I get in touch with my ophthalmologist, I get formal Hess charting, I get formal diagnosis basically from them, and I'll see the patient back and say, right, you know, and I'll say to the patient, look, you know, there's a pretty good chance that I'm not going to have to do this. Your chances of developing post-traumatic enophthalmos, because that's what we're trying to prevent. Functionally wise, you know, they're not going to have a problem. It's the post-traumatic enophthalmos and a small isolated orbital floor defect with no evidence of any incarceration. I probably wouldn't go in basically. I would probably just leave well alone basically.
But specifically asking about the nerve compression, I mean, do I wait and watch for the anesthesia to go away, or should I go in?
Nerve compression. All right, that's different.
Are you talking about infraorbital nerve? Okay.
The infraorbital nerve, it's unusual for there to be infraorbital nerve compression with an isolated orbital floor fracture, yeah? You do get, yeah, but with a zygoma, that's different, yeah? If you've got an infraorbital rim fracture, that's different ball game basically, yeah? And then you're thinking about, yeah. But I've seen lots of my patients who have come back, I've fixed them, and they still got paresthesia, but does it bother them? No. You know, because you go and see them and say, how's your numbness? And they go, oh, I've forgotten about that. Yeah, very rarely. And it's like, you know, when we do mandibular trauma and patients have a numb lip and they come back and see you 6 months, how's your numb lip? Oh, is it? Oh, it's still numb, doctor. And, you know, they've forgotten about it because they've adjusted to it and stuff like that, yeah. So it's interesting, you know, patients do tend to adjust. Different if it's, you know, a cosmetic problem or a motor nerve or something like that, that's different. Thank you.
Just in case I need to, I can wait for about a week or
yeah, you've got a window of opportunity of 14 days, yeah, at least. I mean, I've operated 14, 18, 19, something even 21 days and stuff like that. You know, it's when you get to that 6-week period, don't go in, treat it as a secondary procedure. It's a post-traumatic case. You can treat it in 6 weeks or 6 months, doesn't matter basically, yeah.
Thank you very much, ladies and gentlemen. You had a very invigorating question-answer session. Scientific committee, please come and do the honors. We are at the end of this session. Please do not go, Gopal. They want to felicitate you, all of you.
To present memento to our honorable speakers for the session, Dr. Andrew Edwards, Dr. Gopal Krishnan sir, and Dr. Vikas Zuper. This brings us to the end of an exciting craniofacial trauma session, the master's stroke. Can we have a round of applause for our speakers, ladies and gentlemen? Dr. Gopal Krishnan sir. Dr. Vikas Zuper sir. Now I request Dr. Rahul Chajlani, our International Speakers Coordinator, to please come and present a memento to our chairperson for this session, Dr. Ashok Dabir sir, Dr. Rahul Chajlani. Now we'll have a 30 minutes interesting session by Dr. G. Krishna Ananda. It's a video presentation on osteomesh in orbital floor reconstruction. Ladies and gentlemen, I would request you to please be seated, but we also have a very good arrangement for all the delegates. We have the lunch starting from 12:30 and ending till 3 o'clock. So in case you want to go, have lunch, come back to ensure the scientific session goes seamlessly. The video session by Dr. G. Krishna Ananda.
Orbital reconstruction simulation experience using OsteoMesh, a product by Osteopore. I'd like to inform that there's no financial interest on my end. The pictures over here are shared for medical purpose, okay, and patients' information, patients' data to be respected at all times. And these images are not to be shared in the social media or in the internet without prior permission. This is part of the map of Malaysia, and I am somewhere down here. And this is Singapore. Osteopore is from Singapore, and I'm somewhere around the border, working around here in Gleneagles Hospital, which is a private tertiary hospital. Okay, we'll go straight to the matter of the day. Why we reconstruct orbital floor, and how do I use the OsteoMesh in my reconstruction. The most common reason for reconstruction of orbital floor in Malaysia is usually due to trauma to the periorbital region, tumor involving the periorbital region, and sometimes there's infection at the periorbital region, which can be osteomyelitis, fungal infection, something called silent sinus syndrome. Oral maxillofacial trauma is a common injury in Malaysia. Fracture zygoma is commonly seen. Orbital floor and walls are commonly fractured due to this impact. And concomitant fracture may cause bone loss at the mid-facial region. Facial trauma contributing to orbital defect based on the fracture types, zygomaticromaxillary complex fracture, frontal nasal orbital, ethmoidal orbital complex fracture, NOE fracture, Le Port 3 fracture, Le Port 2 fracture, and also isolated orbital blowout fracture. So, in my lecture today, we're going to look at what are the issues that we face. Most often than not, is because there are issues with the eye. You're seeing double diplopia, the noctalmus, the eye is sunken in. The herniation of the orbital content without marked noctalmus at the presenting period. During the first week of the surgery, first week of trauma, we don't usually see any noctalmus. That is because masked by swelling around the orbital region. In kids, we see a lot of trapdoor fractures, and sometimes because of the fracture, the bone gets displaced and the spatial asymmetry. So when we tend to fix this bone, which is being displaced, that creates orbital floor defect that requires repair. As you all know, that orbital floor repair can be done in many ways. Okay, using natural bone, using patient's own bone, also genius ways, and also others, as was stated over here. Okay, and the types of bone that the places where we can actually harvest this bone are actually from the anterior maxillary sinus wall, the coronoid of the mandible, the mandibular ramus. Okay. But most often than not in my practice, I usually take it from the calvarium inner table and also from the anterior iliac if I were to do osteogenous bone grafting. Other than that, we have titanium mesh, reform orbital mesh plate from Synthes, Synthor, Matfor, resorbable orbital plate. The use of Matfor has been declining over the years, has been associated with infection. Okay, and since the freeform orbital plate is there from Synthes, a lot of people prefer this as an easy way to reconstruct the orbital floor due to the anatomical freeform anatomy of the floor of the orbit. There comes bioresorbable material which are osteoconductive. We have glycolic acid, PGA, we have PLA, we have PLGA, we have polycaprolactone, PCL, and we also have polydioxanone, PDO. So these are all the bioresorbable material which is available today, and polycaprolactone has its benefit because it does not have an acidic byproduct formation. It has good structural stability, and the PCL matrix also allow biomimetic environment for the initial blood coagulation, cell infiltration, new blood vessel formation, and effective long-term osteogenesis. So this is the product from Osteoform, which is a PCL bioresorbable mesh, okay, which has a similar strength as a trabecular bone. So what I'm going to share here are my personal experience using OsteoMesh and different types of materials in reconstructing the orbit. So, in my earlier days, an orbital floor fracture, orbital or titanium mesh is usually used to reconstruct, and we fix this mesh to the orbital ring. And this has been the standard of care for many years, and even today a lot of people are still using titanium mesh. And then this is OsteoMesh, also in an orbital floor defect over here. You can see that can be cut and shaped without any extension to the orbital ring. And in some instances where it requires extensive reconstruction and something more sturdy, where the defect is huge, I tend to use hip graft. And if you can see, with the use of hip graft, there's two-side surgery, and the surgical hours become much longer. We go up to about 4 to 5 hours to complete one case. This is a case of one of my patients who had a facial bone fracture and was operated in a different center, and she came in complaining of facial asymmetry, diplopia, post-surgery. And this is the CT scan of her surgery, the previous surgery. You can see that the lateral orbit region was not well reduced. The zygoma is placed more anteriorly, and that gives that extra height to the cheekbone. And you can look at the defects seen on the lateral orbit and also on the floor region actually. And this is post-op, where we have osteotomized the bone, reposition it and plate it. Due to the delay in the secondary reconstruction, the nasal region was not osteotomized because there was not much of a defect seen clinically. Now, the floor of the orbit was reconstructed with OsteoMesh. And this is her 6 months post-op. You can see the position of the eye much more forward. Yes. And the cheek is much more symmetrical. Not much changes are seen in the nose. By the way, this patient actually had Bell palsy, so she has right facial weakness. She's been diagnosed with Bell palsy for more than 20 years. So over the years, from 2013, this is part of my record. You can see my first introduction to OsteoMesh from Osteopore was in 2015. Prior to that, I was using autologous bone and then titanium plates, titanium orbital plate mesh. Fractured zygoma in any direction that I want with the same incision. And once this is done, we explore the orbit, okay, clear all the herniation, plate it, and prepare the floor with OsteoMesh. So, and this is the patient 1 day post-op with no restriction to his eye movement, not seeing double, but of course there's marked swelling around the opposite side. And post-op almost symmetrical, and the good part about this is there was not much complaint in terms of electrical feeling, tingling sensation, this aesthesia around the orbital region, and is able to hold the orbit, the eyeball in its position. And today with technology, I've also moved towards navigation surgery and use computer-aided surgery here in terms of planning the surgery and also navigating towards navigating within the orbital region. So, computer-aided pre-surgical planning is important, and especially managing complicated orbital traumas. So in complex orbital reconstruction, navigation is indicated. So this is one of the cases. This is a 29-year-old Chinese male who was fell from height, who had a laceration over the forehead, sutured in another place, came to the hospital, okay, with a complaint of nocturnus. He does not have any diplopia, nor did he have any restriction to eye movement. 1 week pre-op, UFM grossly full, no nocturnus, no diplopia. So this is a work order in terms of navigation. Okay, so just as a guide. And this is the system that I use, BrainLab. All the planning is placed into the system prior to surgery. And with the help of this navigation system, I'm able to reconstruct defects which are deep within the orbit towards the ledge. And in theatre, this is how we prepare the patient. Okay, with the array placed on the forehead and navigation work done prior to surgical draping. And intraoperatively, we are able to navigate this area, the orbit, and get into the defect area, clear the herniation. Most of my approach today is transconjunct with kenkotomy. And this is osteomesh, 5 by 5 centimeter. Okay. It has two different orientation. One is a bit more firm than the other. So you can choose the firmer orientation by placing this into the orbital cavity. So intraoperatively, once the tissue which is herniated is cleared, we go through, we look at the area that we're going to place the osteomesh, the area between the medial and the inferior region is an important landmark. Okay? And this reconstructing this area would return back the volume, lost volume, and of the orbit, and therefore we could able to correct the nocturnus. Okay? And with the help of navigation, we basically know where we are. And that's what this picture is showing, that I've gone deep under the fracture, okay, and gone beyond, so I am not getting up to the ledge. So with the help of navigation, we're able to reconstruct, and osteomesh is able to rest well in this area and give you that lazy S curvature with a bit of molding intraoperatively. And this is important so that we also don't over dissect towards the nerve, the optic nerve region. Any damage to the optic nerve can lead to blindness. This is the patient post-op, a bit of hypertrophy, but that has settled since. It's more due to the swelling. Osteomesh also can be used as a patient-specific implant. We have two patients. So this patient came to us 4 months post-trauma, and he had a medial floor fracture. You can see from the CT scan over here that there's a loss of ethmoidal air sinus, where the medial wall has pushed into the ethmoidal air sinus, and because it's been 4 months, so we decided that, and since it's only an isolated orbital floor fracture or orbital fracture, we decided to have a PSI done to return the patient's volume. Okay. Patient is not back for follow-up, but there's no nocturnus at the moment. I'm still collecting post-op pictures. This is a recent case. So in conclusion, the PCL sheet mesh has good long-term outcome. There's no complaint of dysesthesia from reconstruction of the orbital floor. In the last 7 years, I've not seen any infection. I've not removed any osteomesh. There's minimal post-operative complication in terms of displacement, pain, and good fracture strength. We are able to do patient-specific implant. and it also can be used in conjunction with navigation system. So if there's any question and answer, the next question and answer session is any question, I'll be more than happy to accept the questions. Thank you.
And welcome to the 5th convocation of the International Board for the Certification of Specialists in Oral and Maxillofacial Surgery. It's really been a difficult time since our last convocation, where COVID hit and our examinations were postponed for at least a year, and then having to develop a fully online version of the examination in a short period of time. It brought different problems, but it solved other problems. And we're pleased to say that we have had 2 complete diets of the online examination, and just yesterday we completed a hybrid examination where all the examiners came to indoor, and we continued the examination with the candidates online. So I'm Paul Sambrook, I'm the current president. I would like to introduce Dr. Mark Wong, our previous president, Krishnamurthy Bonathaya, our vice president and soon to be our president, and Praveen, who is going to help out here, our fellow in oncology and general fellowship. As you know, we now run 2 fellowships, the General Fellowship and the Fellowship in Oncology and Reconstruction. And both of those are now run without any prerequisites. So you no longer have to sit the General Fellowship before you can sit the Fellowship in Oncology and Reconstruction. So by the power invested in me by the Senate of the International Board, I would like Dr. Bonathaya to present the candidates for the award of fellowship.
Akash Kohli.
Please come up onto the stage when your name is called. Yeah.
Akash Menon. Akhilesh Kumar Singh. Farooq Hasmukh Wanza. Catherine Diana Ponraj. Charudatta Sridhar Nayak. Kishore Kumar Venkata Raya Durgam. Lakshmi Shetty. Madan Mishra. Prashant Dilip Chopra. Rashmi Rai. Gandhiji himself. Ravi Veera Raghavan. Rohit Chandra.
Thank you very much, sir. Thank you.
Congratulations.
Thank you very much, sir.
Congratulations,
Thanks, bro.
sir.
Thank you.
Suraj S. Srinivas Gadipalli. Congratulations. Srinivas Gadipalli. Congratulations.
Congratulations, sir.
Vani Mehrotra is in absentia.
Thank you.
Sure. Next time you come around yourself. Yeah.
I need mine now.
Yes. Vishal Kulkarni. He's from the army. Yes. Yes.
Thank you so much. Thank you so much, sir.
Congratulations.
Thank you so much, sir.
I think you are the first one from the Indian Armed Forces who's done this.
Is it, sir?
Yes.
That's nice to me. Thank you so much, sir.
Congratulations.
Thank you, sir. Thank you. Thank you, sir.
Take care.
It's fantastic that you're able to come along, and we see the recognition of all of that hard work that you've put on. I would like to recognise the Senate members and the examiners that have come to Indore to run our latest exam, and the examiners are also very grateful for you sitting the exam, otherwise we'd have nothing to do. And the last person we'd like to recognise is Sanjeev Nair, the incoming president of the International Association, and he's been a great supporter of the International Board for many, many years. In fact, has participated in every single exam process that we've had since its inception. And so we thank you for your ongoing support, Sanjeev. I'm sure we'll have many, many, many more years together. We wish you well for the future, and we look forward to seeing you at our next convocation, which is likely to be in Vancouver in 2023, followed by Japan later on in that year. So we wish you all the very best, and safe travels to wherever you're going to go from here. So good afternoon.
Gopal, please. Come on.
You're going to stand a bit further back if that's okay.
Very fast. Yeah. Gopal, come. Fateh. Gopal sir.
ढंग से खा पी नहीं पा रही थी, और मेरा उस दौरान 10 केजी मेरा वज़न रिड्यूस हो गया था। काफ़ी अपने आप को कमज़ोर और डिप्रेशन में महसूस करने लगी थी मैं। बच्चे भी बहुत परेशान थे, लेकिन मुझे बहुत सपोर्ट करते थे मेरी फैमिली, मेरे हस्बैंड सभी, कि नहीं आप ठीक हो जाओगे, कोई दिक्कत नहीं है।
Their only hope rested in the hands of a unique group of experts, oral and maxillofacial surgeons. Oral and maxillofacial surgery is a unique, internationally recognized specialty that bridges the fields of dentistry and medicine. It focuses on reconstruction and rehabilitation to treat diseases, injuries, and defects in the jaws, face, head, and neck. This multidisciplinary stream has seen amazing advancements in recent times. Oral and maxillofacial surgeons leverage cutting-edge technology to perform zygomatic implants and patient-specific implants for faces mutilated by black fungus removal surgeries. The surgeons take advantage of 3D printing and reconstructive models to develop and reconstruct facial bones and all the lost structures, including teeth, to achieve perfect aesthetics and functionality. Thanks to Make in India, many of the equipment and materials used for this reconstructive surgery and treatments are now indigenously developed in India.
तो फिर उसके बाद इम्प्लांट हुआ। इम्प्लांट में मेरे फिर उसके बाद में 2-2.5 महीने बाद फिर मेरे टीथ लगाए गए।
AOMSI at the beautiful and clean city of Indore. Quite a few of you have been here for the pre-conference courses since 2 days and have been devouring the scientific feast all day today. But that's not all we have to offer. Indore is the food capital of India. The poha from Chappan, the bhutte ki kheer at Sarafa are some of the mouth-watering delicacies that all of you must try. We are known for our street food, and that, you know, comes with tons of litter. However, Indore is the cleanest city of India, being awarded in the first place for 6 times by Government of India. Standing from up here today, I see everyone dressed in beautiful attire, showcasing their culture and rich heritage. What better way could there be to mark the celebration of Azadi Ka Amrit Mahotsav, 75th year of democratic India's independence at the heart of Bharat, or India, in Madhya Pradesh. This indeed is a proud, proud moment for us all to be united in our diversity. Indian heritage and traditions are very dear to us, speaking of which, we would now begin the ceremonial parade of AOMSI. Could I please request everybody to line up for the parade and the band to get ready? Past President AOMSI 2001 to 2002, followed by past presidents of AOMSI, past secretaries, past treasurers, past editors, vice presidents, chairman fellowship committees, chairman IBOMS, AOMSI conference secretary, AOMSI president, president-elect, vice president, honorary general secretary, chairman of the scientific committee, organizing secretary, all executive committee members, all members of organizing committee. I have goosebumps here today. It seems like the whole of India has come into the heart of India in Indore here. Such rich culture and heritage. Ladies and gentlemen, it is now time for the prestigious Jinwala oration. This prestigious oration is in memory of Dr. M.S.N. Jinwala, the father of oral and maxillofacial surgery in India. It is my privilege to call upon stage our esteemed AMSI President, Dr. Manjunath Rai, and Vice President, Dr. Bhagwan Das Rai, to chair the Jinwala oration. I hand over the podium to you, sir.
Good evening, ladies and gentlemen. Extremely sorry for slight delay in the schedule. So we are all waiting for the prestigious M.S.N. Jinwala oration by Dr. Krishnamurti Bonantaya. Before we proceed to that, let me just introduce why we have this oration in the name of Professor Dr. M.S.N. Jinwala. So he is a pioneer of oral and maxillofacial surgery in India. He did his LDSC from Mumbai in 1938, DDS from Canada in 1940, and he did various other postgraduate degrees as well. So he was, when our association started in the year 1969, he was the first president of India. And we can all say that he was a former dean and professor emeritus from the Department of Maxillofacial, Plastic and Oral Surgery in Nair Hospital Dental College, Mumbai, India. He was given an honorary plastic surgeon to St. George's and KM Hospital, Mumbai from 1945 to 1955. So he has this illustrious career in his, and he was the one who lifted our specialty. So we call him as the pioneer of oral and maxillofacial surgeries of India. So in his name, we are doing this oration. So we are all waiting for oration speaker, Dr. Krishnamurti. Before that, Dr. Bhagwan Das, Vice President, will introduce you to the oration speaker.
Good evening, everyone. It's a privilege today to stand here to introduce one of my mentors, Dr. Krishnamurti Bonantaya. It's said that after a certain period of dedication of service to their profession and patients, a name needs no introduction, and Krishnamurti sir is one among them. But Dr. Krishnamurti Bonantaya is special, and he had people rooting for his success since his early days as a young maxillofacial surgeon. Even as a medical student at KMC, Manipal, after completing his master's in oral and maxillofacial surgery and a 2-year stint in UK, he kept himself surgically and academically active. His colleagues and mentor knew he was cut for a different mold and watched him work with immense passion in all aspects of maxillofacial surgery. From cancer to deformities, a journey none can emulate, taken by him, a giant leap after a great stride. It was in early 2000 that he was finally settling into the field of cleft deformities. In 2005, Dr. Krishnamurti started the Bhagwan Mahavir Jain Cancer Unit as a Smile Train project director, and this unit is now responsible for treating over 10,000 cleft patients. As a professor at Bangalore Institute of Dental Science and Fellowship Director of Rajiv Gandhi University of Health Sciences Accredited Fellowship in Cleft Lip and Palate Surgery, he is responsible for not just training but fulfillment, the dreams of an entire generation of maxillofacial surgeons. In the words of his students, a mentor like no other, who not only teaches them how to fish but also shows them where to fish. His students from SGM, Dharwad, A.B. Shetty, Ambedkar, Dental College, Bangalore, and BITS keep in touch with him to this day and seek his words of wisdom when in doubt. Invested in growth of every individual he works with, it's no surprise that his team at Bhagwan Mahavir Jain Hospital were most suited to become the country's first Smile Train Cleft Leadership Center. Dr. Krishnamurthy's leadership qualities and adept medical practice norms have earned him the position of Chairman of Indian Medical Advisory Council for Smile Train. In his outstanding career, he was the editor-in-chief of our Journal of Maxillofacial and Oral Surgery, was president of AMSI, president of Indian Society of Cleft Lip and Palate and Craniofacial Anomalies, published a comprehensive book, Oral and Maxillofacial Surgery for the Clinicians, as the chief editor, and is also the vice president of the International Board of Certification of Specialists in Oral and Maxillofacial Surgery. A journey so complete and illustrious that it would be a moment of pleasure for all of us, members of the AMSI, to hear Dr. Krishnamurthy Ponnanthiya deliver this prestigious Jinwala oration at the 46th AMSI at Indore. Ladies and gentlemen, give him a big round of applause, and I would like to welcome Dr. Krishnamurthy, sir.
Ladies and gentlemen, please check your WhatsApp messages from the organizers to participate in the public poll, which is a part of this prestigious Jinwala oration. Over to you, sir.
Thank you very much. That was a good amount of fanfare and also some sartorial symbolism evident here at Indore. Thank you very much, Mr. President, sir, for giving me this opportunity to be here. In the next 40-odd minutes, I'm going to expand on this theme. Can we have the first slide? Yeah, sorry. I'm going to spend the next 40 minutes talking to you about this question. After all these years, am I a better human being? And I'm sure many of you will ask this: who the hell cares whether you are a better human being or not? That's an important question, really, to ask. Why should we waste a precious bit of our time thinking about whether this man is a better human being after all these years? Sorry. But what I'm going to really delve into in this lecture is about ethics. Ethics in our personal lives, in our professional lives. So this is not an attempt at navel gazing. This is not an attempt at self-introspection, but it's an attempt at looking at the value of ethics for all of us in our personal and professional life through the prism of my career for the last 30 or 40 years. So if at times it appears as if there has been some dirty linen being washed, that's not what it is meant to be. It's meant to be something where we would all want to look at as to whether the current day values that we propagate, that we practice, is right or wrong. So before I go any further, I want to just explain my concept of ethics, because if you look at to find out what ethics means, you'll find so many different things. Some of them are very complex, but for me, as of now, ethics is simply the distinction between the right and the wrong. In any given scenario, what I am doing, is it right or is it wrong, is what the question I would like to ask. And I would like all of you to answer these questions as we go along the journey of the last 3 or so decades with me. When I first heard about ethics, it was when I was a dental student, and when we studied the public health dentistry, there used to be a chapter, a class on ethics, and the only thing I remember from those days is that you had to have a board of a particular size that you could not advertise. So that was my limited understanding of ethics. But surely it encompasses every single aspect of your life, and that is what I'm going to discuss in the next few minutes. Before I do so, this oration is dedicated to all women maxillofacial surgeons whose courage, commitment, and dedication in the face of all adversities and the handicap that they have will remain a font of inspiration for the rest of my life. We have to assume certain things, and one of the important things for somebody like me are the birth-related advantages. I was born in a middle-class family that valued education. More importantly, I was a male. So all the privileges, all the perks, all the focus was on the male children for many, many years in this country, and still continues to be. And therefore, to talk about meritocracy, to say that I am a child of meritocracy, is a bit of a hypocrisy. We will have to see from where we started, and meritocracy is not some empty word. We must understand the handicaps. We must understand the problems that so many, what in science we would call as risk factors, that was associated with a person before he started his journey. And I would like to acknowledge that I have been privileged to be born a male and upper middle class person in this world, and that is a privilege that half of the world doesn't have. I would like to thank Dr. Manjunath Rai, Manju we call him, for giving me this opportunity to do this oration. And I'm also very proud to say that he was one of my students when he trained in maxillofacial surgery at Mangalore. And I think I was a medical student then, trying to do some work on the side, as they call, side business, right? So we will start off, if we are discussing about ethics, let's start off with the ethics of my selection as this orator. Because it's better to start examining all those decisions, because we want to know whether it's right or wrong. Obviously, in many instances, what is right and what is wrong is subjective, and therefore might be a reason to debate or argue things. So we will start off with, was my selection as an orator here ethical? There is my student who has become the president of the society. He is the one who mainly decides who is the orator, and he turns around and says, Kitta sir, you do this oration. Is that ethical? Is a very important question. And I really know, I know people who are sitting here in front of me, a number of them who are as qualified as me or better to do this oration, but fortunately or unfortunately, this falls on the president to make a choice. And therefore, a question needs to be asked, has it been an ethical decision? I had this dilemma a few years ago when a friend of mine asked me to do this oration. A close friend of mine asked me to do this oration a few years ago when he was a president. And I was happy, but I told him, boss, I won't do this because people will say that this is favoritism, this is cronyism. That is a problem. And I will leave it to you all to judge whether it has been the right selection this year to select me as the Jinwala orator. I am proud of doing this, but there will always be a question that will be asked. So I'm going to divide the rest of this talk into two parts, my personal journey and examine how ethics changed for me and how I made decisions which might have been ethical or otherwise. And we will also look at my journey, because this is an AOMSI meeting and I have been very active, some people say too active unnecessarily, as part of the AOMSI leader, and therefore we will also examine what happened in those years as well. When I was going to school and my plus 10, I used to be an atheist. I used to have socialism as my, infantile kind of imagination. I never thought I wanted to become a doctor, but I came from a family of doctors, and at one point of time, the peer pressure was so much to get into medicine that I decided, and by that time it was too late because I didn't study well to get into a medical school. And then my dear father said, I have some money with me, I can get you a seat in one of the private colleges. We had KMC Manipal those days, and still burning with the fervor of socialism and meritocracy and all those concepts, I refused that seat. And ironically, 13 years later, when I was 30 years of age, I became a medical student at the same college where my father had offered to get me a seat in 1980. So after having done dentistry, why did I choose maxillofacial surgery? In those days, people like Sanjeev and Guna will remember, the most important branch in dentistry was orthodontics, and if you did not become an orthodontist, it was a waste of time. And that was the time when we all did oral surgery. But why did I do oral surgery? I was a very ham-handed dentist, couldn't do much, and my choices were to do surgery where there will be some blood and gore, and so I thought. And funnily enough, it's difficult for me to think of it now, but funnily enough, my second choice was public health dentistry. Can you believe me? And do I see a Professor E or a Dr. F in the audience thinking what it might have been if this guy did not become an oral surgeon? Well, that is what life does to us. So why did I do medicine then at the age of 30? It's a very, very interesting question. This is something that dogs me all the time. And nowadays people ask, Kita, if you're given a chance, would you do this again? It is a difficult question to answer, but to keep up my face, I have to say that I will do it again. That I think is the answer. But why did I go into medicine at the age of 30 years? It's very simple. Again, I will fall back on people of my generation who are doing maxillofacial surgery in medical colleges. It was very difficult to convince. This is where it all started. It was very difficult to convince most of your medical colleagues that you were also a worthy surgical specialty that did good work. I remember in my early days, there was this child who had come in with some wooden stakes that had gone into the cheek as a result of a fall from a tree, and then it had become an abscess because there was a piece of bamboo that had broken inside the cheek, and we went in and removed that, and there was this very sarky anesthesiologist who said at the end of the procedure, oh, dentists also have some role to play. But funnily enough, 20 years later, I saw his son was doing dentistry at Chennai. That's another story. Right, so it was a situation where we ourselves felt inadequate because as we upped the game as far as surgery was concerned, as skills were being acquired, there was this lurking background, a doubt that we were not real surgeons, that we did not belong. And then I went to the UK, studied there for a few years. I also had a mentor those days who's not in this meeting today. His name is Krishna Shama Rao. Some of you might know him. And he had a serious influence on me, and I followed him into medical school a few years later. But this is where the story of my ethics also starts. There was times when I went through to school, writing exams every few months, trying to become a doctor all over again, that I had very serious doubt. What am I doing here? When I see my colleagues, like for example, there was Dr. Mustafa in the same place that I was a medical student. He was a cleft surgeon that was being heralded in various news magazines and stuff, and I was wondering, what am I doing here? And what is he doing? So in those days of doubts, one of the things that struck me is that maybe one of the reasons why you need to have this medical qualification is to become a better human being. Why? Because I could understand, by spending all this time, I could understand the issues that are related to my patients much more clearly, and probably I would take decisions much better and rightly. So this is the time of self-doubt when I started thinking that yes, this one of the reasons why I might be doing this is to become a better human being. You know, you always develop arguments that makes you calmer when at turbulent times, and this is one of those thoughts. I'm not saying it was right. My training as a surgeon, a lot of lessons were learned. Once again, going back to 40 years ago or before, there was hardly anything that you could call as structured training. I hope Dr. Moni Kuriakose is here today. We were having a fellowship committee meeting, and he emphasized very strongly what structured training programs are all about. This is for the AOMSI fellowships that we run. And 40 years from the time I trained, we still are having to emphasize that structure and processes are important because we are treating human beings. But in our times, it was not so. I worked with a number of very senior head and neck surgeons in the UK, and if you were a real surgeon, you did head and neck surgery. The other things were all waste of time. You just potted around. But if you did cancer surgery, you are the big guy. And those were the days when they were learning how to do free flaps, and many flaps I saw being thrown into the bucket by my consultants as they went up their learning curve of managing these patients with head and neck oncology. So this is a saying which even today I hear sometimes. As a joke, it is fine. See one, do one, teach one. As a joke, it's fine. But if that is what happens in practice, it is a disaster most of the times, not for yourself, but for your patients. And that's where the concept of ethics rears its head. If I have to do a particular surgical procedure, if I want to treat these patients, do I have adequate training to venture forth is a question that we need to ask. And these kind of aphorisms are anomalies and nothing else. And that was what happened in our case. Most of us, Sanjeev is sitting here, he'll agree, are self-taught surgeons. Sometimes we did not see one, we read one and did one. So that's not the way to go forward, and that's the wrong way. There's no doubt about it. And so therefore, what is the way forward? Today, as we go on, the most important thing to get adequate exposure, not only to your hands in terms of psychomotor skills, but also to your brain, is simply simulation. Simulation is what is taking over educational fields, particularly in medicine all over the world. And simulation is what we have to adopt in a big way. And I request the president of the AOMSI, the secretary of the AOMSI, to think hard, and as we, and the president that is going to take over, to think hard and see whether we have a role as the professional body of maxillofacial surgeons, whether we have a role in developing a program that puts simulation at the forefront. This is something all of us have to think, and that is where your ability to operate, your ability to treat your patients with adequate amount of confidence and skills without having to experiment on them will be very useful. So this will be the first question that I would like to answer, the audience to answer. I hope the internet works here. So you have something called as the menti.com. You can use that, go to that, use the code. Is the net on, Deepesh? Can you just check? So this is the question for you. The answer is yes or no. I hope we have the internet working. We want to know how many of you, please answer this question. I'll just make sure the net is working. We have a little bit of a poor internet here, but we will see. Please, menti.com, and what is the code number?
They have already got it.
Who?
All of them. So
yeah.
Got the code.
Please try to answer if your net allows. And the question is, would you still opt to be a maxillofacial surgeon if dual qualification, i.e. medical and dentistry, is made mandatory? No? Just give me a few seconds. We are trying to fix the internet. This is going to be a very interactive lecture. I have 5 questions to come on, and most of these are questions that I like to ask once I have discussed these things. Something went wrong. So the net's not working here, but we'll try and fix it and see if we can get the responses. The responses will come on if there is an internet available. Can you use your phone? Is it there? Huh?
Not coming on.
What a shame. We'll try one more time and then move on.
It's there. Connected. It's connected.
Sorry, we will have a show of hands then while we wait for this. How many of you would opt to be a maxillofacial surgeon if dual qualification is mandatory? Raise your hands. Oh, wow, we don't need the Mentimeter. Is the next slide going to come, Deepesh? Yeah, so without the Mentimeter, that is an overwhelming endorsement that people who are training and train maxillofacial surgeons, including our secretary, would like to see that. Okay, we'll go on. I'm just waiting for the next slide to come on, sorry. Okay. It's not moving. Huh? No, we are okay. So, talking about the training, how did I, oh, sorry. Sorry. Okay, going back to my training, how did I then become a cleft surgeon? Remember, the idea was to become the all-conquering head and neck surgeon, but it was serendipity. Serendipity simply because what happened in this country a couple of decades ago was a revolutionary change in the ability for us to treat children born with cleft lip and palate deformities, and I jumped into the bandwagon. And that was the evolution. Now, one of the important things that bothers me these days are the pros and cons of being a generalist maxillofacial surgeon versus a subspecialty surgeon like me. For the last 2 decades, I have to confess that all surgical procedures that I've done are related to the cleft lip and palate patients or their problems, though I am a maxillofacial surgeon. So this is a debate also that is going on amongst a number of forums, whether you need to be a generalist or you need to be a specialty practice. But for me, it has worked very well simply because, remember, I was a ham-handed dentist and I was not a great surgeon as well. I was not a natural like someone like, say, Saidul Islam, who once told me that if he watched a surgery, he could perform it. And we all know how well evolved he is, how highly regarded he is as a cancer surgeon today around the country. But that's a gift. But for somebody like me who had to learn surgery the hard way, it was so much easier to deliver better care and outcomes to my patients if I stuck to a narrow range of work day in and day out. You will remember the example of the Sholdis Clinic, which is there in Canada. Sholdis was a doctor who came out with a procedure for hernia, and he has a clinic where the only procedure they carry out in the hospital for day in and day out is the Sholdis repair of hernia. And most of the people who perform these surgeries are just medical doctors. They're not trained surgeons. And they have shown that in the world they get the best results in hernia. Right? So that is the question that we need to ask. That is the question we need to ask. Are my surgical end goals patient-centric? Am I doing a surgery so as to get an endorphin release, to get the feeling that I am the alpha male of female? I don't know whether there is a female version of alpha male, but I assume there is. Is there? Yeah, Yashaswini? Yeah. So, am I trying to become just an alpha male that can do the procedure in 20 minutes and walk out for my beer? Or am I worried? What are going to be the outcomes? This to me is a big ethical question today. I hear my juniors, my students, a lot of times saying, oh, nobody is allowing us to cut. And I don't know whether my friend Aditya is here. He had written when he was a student in an old book, which he put it on Facebook the other day, to cut is to cure. That, my friend Aditya, is not true. What is true is to make the right decision, whether to cut, when to cut, how to cut, why to cut, and whether I should do it or somebody else should do it. If, for example, I have a case of temporomandibular joint reconstruction today, I would look at Professor Roy Chowdhury and say, boss, will you do this for me? Because I know he has done hundreds of them. He has shown that outcomes are very good, and therefore it is so important, whatever may be our career aspirations and goal, to reach a level of thinking where we know, we decide what we want to do, and that is based on what we want for our patients. So with that, I come to my second question. If it doesn't work, we will do a hand show itself, simple old-fashioned thing. I have a friend who is a good technologist, but he is let me down today, but we'll use hand show. Do you sometimes think before finalizing a treatment plan, would I do this for my parent, the same treatment, my child, or my spouse? Do you sometimes think? Raise your hands. Wonderful. Really wonderful. This is one of the first lessons I learned as a young surgeon. I was in Sunderland in UK, and there was this young consultant bubbling with ideas. He had just become a consultant 3 months ago. Some of you might know him. His name is Leo Stassen. And this is the first lesson he taught me when I stood at a clinic and was watching him see patients. Would you do this for your mother, for your sister, or your child? If you would, go ahead and do it. This is what he said. All right? The other area that I want to quickly cover is about teaching. I've had a whole lot of triumphs, but many more trials and tribulations as a teacher. This is something that I like more than doing clinical surgery or research, the three wings of a good clinician. This was what came to me naturally. But over the years, there have been people who have come back to me and said, you are a useless guy. It is important for us to understand what is it that your students, your trainees need. You cannot always determine this is what they should have. And this is something which people of our generation are not well taught. And I have had feedbacks on my face from my students who said, you were no good. So there were a whole lot of trials and tribulations. But as Bhagwan said earlier, I've had the privilege of training people in cleft lip and palate surgery, and from the time I started doing this, when I say it's me, it's a team, and fortunately for me, I had a surgeon who was so much better than me in doing these surgeries, so we were a team. He was formerly the secretary of this association. His name is Preetham Shetty, most of you will know. So as a team, me and Dr. Preetham, we started training people, and you see the effect from Bangalore all over the country. We have one of our fellow in Trivandrum, we have one of our fellow in Srinagar. This is Bharat Jodo without politics. We have trained people from Iraq, from Sudan, from Oman, from Israel, thanks to the International Association of Oral and Maxillofacial Surgeons, who recognized us as a training center for cleft lip and palate. COVID has brought it to a halt, and we will see what happens. So this is a true force multiplier effect, that what you cannot do being in a single place and treating patients. Train, train, and train more. We will discuss this a little more when we talk about the association. Now this is the other thing. Sanjeev and me were editors of the Indian Journal, and so many times people would come and tell us, boss, please get this paper through. I need it for my promotion. No problems at all with that. Everybody in this world of publish or perish, it's important. But is research only for promotion is the question that we need to ask ourselves. Sorry, ignore the busy slide. Basically what we did in the last 15 years, we had very poor grounding in research methodology, unlike people from the West or Europe. But we picked up on a few things, and if you are able to read, which I know you can't, you will see that our publications are a series of things, what we learned. Now this one is on a set of, in a condition called nasoalveolar molding, where we started off with describing the technique of nasoalveolar molding, looking at its effect, short term as in correlation of vermilion symmetry, a long term study at 8 years of age of growth of these patients, compared them. We devised a scale to measure outcome of bilateral cleft lips, and then compared the results in our own group between nasoalveolar molding and no molding. Also looked at long-term comparison. This last paper, number 7, has recently been published in the Plastic and Reconstructive Journal, where we looked at long-term results of the nasolabial aesthetics between molding and no molding. So what I'm trying to say is this is a spin-off of your clinical work, that you then start gathering good level of evidence for clinical practices that we commonly use, and it's extremely important, not just for promotions. And this is the second set of studies that we have done on speech after cleft palate. It's been part of a PhD from my speech pathologist. She did it in the All India Institute of Speech and Hearing at Mysore, and part of that has been published in the Indian Journal of Plastic Surgery, looking at the way we managed velopharyngeal dysfunction after cleft palate. We looked at our outcomes, and we have come out with a set of data which will predict what will be the outcome if you chose a particular procedure for secondary repair. In this case, it's Furlow's palatoplasty, and this has been published in the Cleft Palate Craniofacial Journal, and it is getting good attention because what we have with our large series of cases demonstrated is what might work and how you might know before you did the procedure that this is likely to provide results, and if it does not, what to do. In other words, we are trying to develop an algorithm based on our outcomes to manage a significant problem of the cleft palate repair, which is velopharyngeal dysfunction. So I would like to recommend 2 of these books to you. The one on the left is from a South Korean economist who settled in the UK. Phenomenally readable, 23 things they don't tell you about capitalism. Evidence is something we also need to analyze. Evidence is not whatever is written in the journal. Remember, a lot of people are writing articles for their promotion. So he debunks, beautifully debunks, the so-called free market capitalism here in this book. It's worth a read. He clearly, with evidence, shows how the so-called free market pioneers, the free market champions who come from, say, for example, the US, to become a superpower used protectionism, used practices which will not be regarded as free market today, and once they became a big economy, started advising everybody to have a free market for all. Beautiful book. Look at what is happening today as well. So we have these champions of the free market who say everything should be open everywhere. But when you talk about that, it is openness not only for goods and services, but it should also be for labor. And they build walls and chains. They throw away people from the boats as they try to come to their shores. They are not allowing free movement of labor. So where is free market capitalism? That's the theme of this book. So why am I bringing this into a discussion here? Because when we talk about evidence, what you think is evidence may not necessarily be evidence. Beware. And then there is Yuval Noah Harari. Many of you have read him. This is his last book, phenomenally predictive, phenomenally interesting as to what is going to happen in the next few years. There are some very stark predictions. I will not bore you with that. But what he says is, we today think that warfare is killing so many people. There's war in Ukraine, there is war in Israel, there is war somewhere else. But he says, in the history of the human race, this is with facts and figures, in the history of human race, today, more people die of diseases than of warfare. More people today die of suicides than of a war. So, though there are wars happening which we don't like, if you look at human history as a whole, we are at a stage where these things are very, very less. So, when we talk about evidence, when we talk about evidence-based practice, it's also important that we learn to not only produce the evidence, but also learn to evaluate it. It's extremely important. Just because it comes from A, B, C, D does not mean it's good evidence. This is something that we need to remember. Okay. Now I'll go to my journey with AOMSI quickly. I think I have another 10 minutes left. Important journey. I never aspired to be a leader in the AOMSI because I was now a frustrated socialist, so did not see hopes of becoming a leader of this August association. I owe it to two of my very good friends who literally lifted me and pushed me into the forefront. One is Sanjeev Nair, other man is missing here. He's brewing all kinds of beers these days. And if you happen to get in touch with him, ask him whether he can brew a nice craft beer for you. His name is Kishore Naik. Wonderful craft beers, believe me. Okay? Sorry. So, till now, the question of money hasn't come up. So I can see somebody at the back of the room saying, this man is grown old, has made enough money for himself, now he's talking about ethics. True. So let's talk about money. Let's look at what happened to the Indian Journal of Oral and Maxillofacial Surgery over the last 10 years. When it grew, we are now not talking about downloads, we are now not talking about citations, we are talking about money just to bring in economy into that. And because we did some things right, in other words, because we were ethical, from 2 lakh rupees or 200,000 rupees royalty in 2011, we reached 26 lakhs now. And one thing will be a feather in my crown for a while, because the highest rate of 30 lakhs was when I was the editor, but I'm not crowing about it. I don't know. I know how it happened. But look at the graph. It went from 2 lakhs consistently now there, simply because we are producing a better quality journal and we are doing ethical journal production. Money follows good ethics. That's what I want to tell you. Whether it is in your personal life, whether it is in your business or practice, you don't need to become unethical. It is not required to be unethical. The AMSI Fellowship Program, I won't speak much about it. I think Girish might cover that in his report today. But an association which is normally regarded as a trade union of professionals belonging to a particular specialty, a profession, a group, here undertook massive education program since 2015. Today we have more than 25 centers in the country which is providing training in the fields of maxillofacial trauma, orthodontic surgery, head and neck oncology, and cleft lip and palate surgery. And this year, I'm glad to tell you, 700 people wrote an exam in order to qualify for these 25 positions. So we do not have a royal college like, for example, in the UK, which takes care of education, and the association, which is a trade body. We have mingled or merged both of these together and have become an association, a group of professionals that cares for its trainees and makes sure that a number of them are well equipped to work as surgeons with this particular program that we are carrying out. And I believe in the coming years, Bhagwan is the chairman of the fellowship committee, these numbers will increase, and over a decade or so we will have a large body of well-trained professionals. Remember, teach one, see one, do one, or see one, do one, teach one. We will not have to do that. And then we produce this book. You can see there is a, what do you call that, a banner there. This book that we wrote as an open access book, spending about 3 million rupees, has had 5 million downloads till date. And out of these 5 million downloads, only 1 million has been in India. Look at where the book has been downloaded, ladies and gentlemen, all over the world. And out of 5 million, just 1 million has been in India. We as Indian maxillofacial surgeons have to feel proud of this. And it is not just where it has been downloaded. Look at the citations. Just look at citations. Just in a span of more than 12 months, we have 37 citations that have come up, and Springer, who is our publisher, says only 7% of similar books have same or more citations than this book. So ladies and gentlemen, I think we have arrived. And look at the field of research where these the publications have occurred from. Okay, there are only a few books on lung cancer, etc., which are getting more citation than us. And where are the citations coming from? Look at that. The citations are also coming from around the world, except Africa and South America. The citations are also coming from the place where people have read the book. And this is what I want to read this because it's important. This came from our editorial director for Books Asia, Medicine and Life Sciences, Springer. Naren put this up in his LinkedIn. Back in 2018, the concept of an open access book was practically unknown amongst the Indian academia and learned societies. At that time, the Association of Oral and Maxillofacial Surgeons of India took a very progressive and bold decision to go for the open access route. Doctors Krishnamurthy Bonantaya and Preetham Shetty at AMSI were the key force to go for OA. I can only imagine this wouldn't have been an easy task to convince the executive members of the society. Traditionally, medical society in India have only chosen non-OA print copy approach for their books, leading to their textbooks being read mostly in India. This textbook has gathered around almost 4 million chapter downloads from outside India, confirming the global relevance of such books. Congratulations to AOMSI and the editors of the book for executing this large project. We hope that more such textbooks will be published by the academic societies in India that are made available in both print and electronic versions for readers worldwide. Another important thing that we took up in the AMSI was faculty development program has been a failure. Bhagwan, I have to say, let's talk about it later. Failures are not something that we will emphasize on today. The other very important educational program that we started in the AMSI is what is called as the Foundation MaxFact program. This is the course faculty with all the participants at RV Dental College, Bangalore at the first course. What we are trying to do here is, in a span of 3 days, we are trying to give a foundation to understanding of systemic diseases that might bother our patients, that might compromise our work, and what kind of approach we need to have to understand these diseases and make sure that when we do our surgeries, be it a wisdom tooth removal or a cancer, we do not end up causing medical problems to them. So this is an effort of the AOMSI. It stopped during COVID. We have restarted it now. We recently had a session at Udaipur, and one of the joys of being the faculty of this program is you get to go to Bahubali Hills in the morning with Bhagwan Das Rai. It's a beautiful place. It's not just teaching children, you also get an opportunity to see some nooks and corners of the country. That's the bonus. But I request all those postgraduate students who have just joined or in their first year to please enroll this program. With the help of our new secretary, Dr. Girish Rao, we are making a whole lot of changes to it to make it user-friendly, to make it technologically useful. Okay, so now this is a very quick question. Do you agree that AOMSI should continue to take a lead in educational activities? Those of you who say AOMSI should not involve in education activities, raise your hands. Because this is what I heard a few years ago from somebody who was a trenchant critic of me within the society. He said, in the last 10 years, this association is doing only educational activities. That's not good. But I think I've got an endorsement, I'll move on. The next important one that I want to talk about is the International Board. We have the president of the International Board here, Professor Paul Sambrook, the immediate past president, Mark Wong. So in 2012, IAOMS incubated this organization, which now gives out a certification, and it's a bit of a tongue twister, International Board for Certification of Specialists in Oral and Maxillofacial Surgery. This is again an ethical question. Why? We are trying to provide a level playing field as far as recognition of training goes in different parts of the world. Everybody sits the same exam, gets qualified, and therefore gets certified by an independent board of examiners from around the world that you have attained decent level of education or training. This, we hope, will level the playing field. And just to show you, as of now, we are penetrating only mainly in India and Japan, where we have most of our fellows. But we have slowly started making inroads into the Middle East, to Eastern Africa, some from America as well. In the coming years, we hope that we will cover the other parts of the world. But today I am making a special appeal to all you young maxillofacial surgeons. Get yourself tested and certified by the International Board. This is not a commercial, but it is a real fervent plea from somebody who has been associated with this for more than more than a decade, that this is how, like we did with the book, we show to the rest of the world that our training standards are as good as it gets. Okay, so before I finish, just a couple of quick thoughts. One of the important differences in doing surgeries, whether you see your patient as an eye or a tooth or a jaw or a hand, it happens in all specialties, or you see him as a whole human being. This, I believe, is the biggest difference in the quality of care that happens, that as far as possible, whenever you can do it, you will have to remember that you're not pulling out a tooth, but you're pulling out a tooth of a human being. And that, ladies and gentlemen, is the crux of the matter. The last topic that I want to discuss is relationship with patients or parents. It's a very important thing. Do we become friendly with our patients or parents? I read a number of articles recently that around the world, doctors like to keep a distance, create a barrier so that they do not get emotionally involved with their patients. But the only specialty, I believe, around the world where there is a good evidence to show that the specialists are emotionally involved, attached, invested in their parents is in pediatrics. And I work mostly on children, and I find that becoming friendly with them, genuinely feeling for them, being empathetic, works wonders. And at this point of time, I want to quote from this book. Many of you must have read this book. If you haven't read this book, you're missing something very important in life. Paul Kalanithi, very briefly, was a brilliant neurosurgical trainee. He was finishing his work, much decorated already at Stanford, who got a tumor in his brain, sorry, was it the lungs, wherever, and died even before he could finish his training. And then when he knew he was going to die in the next 3 months, Paul wrote this book. Incidentally, our claim to know Paul is that he comes from Chennai and eats dosa and chutney like many of us South Indians do, but that's immaterial. Paul wrote this book, and it was finished after his death by his wife, who was also a doctor. And it's a phenomenally emotional book, but you must read it. But one line from that I want to quote from him. He was already a well-trained neurosurgeon, mind you. He says, when you know that your scalpel is not going to do any good, the only tool you have is words. Ladies and gentlemen, this should be the tool that should be employed with all our patients, whether they're dying or not, whether their problems is minor or significant, that we learn to talk to them, that we learn to interact with them. So many times I get people coming in and say, doctors just write prescriptions, they don't have time to explain to us why we should do this and what will happen if we don't do it and so on. This has been the bane. I think Sanjeev, when he did his oration at Nagpur, talked about soft skills in a great deal. I would like to emphasize this, and this comes at a significant moment when I read this book from Paul Kalanithi. So this will be the last but one question. Do you think being friends with your patient is a good idea? Okay, all right. I think I'm getting a yes for all of them. Lastly, what lessons have I learned in life, and how can we keep ethics as the central point of whatever we do? And it's very simply defined as, is it right or wrong? And that's for you to decide. It's for you to decide whether what you're doing is right or wrong. And I think that should be the bedrock of democracy also. For example, there are various regimes around the world where there is brute majoritarianism that is ruling. Oh, we have the majority, we can do whatever we want. After all, we were elected with X number of votes more than the other. That's not democracy. Democracy is where you consult. Democracy is where you discuss. Democracy is where you come to a consensus. And the best example, ladies and gentlemen, that I can see that happens every day is the doodle poll. Those of you who have used doodle polls to fix up a meeting will know. Everybody puts his input. I want the meeting on this day at this time. There is a choice, and from that you choose. That is democracy. And ethics should be the bedrock of democracy. And therefore, I believe that not just in maxillofacial surgery, but in day-to-day life, in politics, in sports, wherever you go, ethics has to be the bedrock. And then we come to the last question of this. After all these years, am I a better human being? I want to know from you. Yes or no? Okay. If it is, how many of you say no? please feel free to raise your hands. I can't come and whack you there. Please. Okay. Thank you very much for listening to this. We'll end it with this song. Can't hear. The audio?
Walk down before you call him a man. How many seas must the white dove sail before she sleeps in the sand? How many times must the cannonballs fly before they're forever banned? The answer, my friend, is blowing in the wind. The answer is blowing in the wind.
Thanks to Bob Dylan and thanks to all of you.
Dhanyavadagalu, sir. Wow, sir. What a journey. As humble as you were through the oration, you're a big source of inspiration for us all. May I please request Dr. Manjunath Rai and Dr. Bhagwan Das Rai to say a few words.
Sir. Sir, I'm sorry. Dr. Krishnamurthy, sir, it was really a privilege to listen to you speak. You were a teacher par excellence. Regarding as far as the oration is concerned, you were a long due. It just happened this year. It was my privilege that, I as a president, you are giving an oration. You saw the viewers' expression, that says it all. So it was always, whatever you do, you always keeps the ethics and moral in, whether it's a role of a teacher, as a surgeon, or your role in the AMSI. You have always lived for your, we all look forward to, we learn every day or every move, whatever you do, sir. Thank you so much.
May I request Honorary General Secretary, AMSI, Dr. Girish Rao, Organizing Chairman, Dr. Rajesh Dhiravani, Organizing Secretary, Dr. Geeti Vajdi Mitra, and Scientific Chairman, Dr. Shaji Thomas, to please proceed to stage.